ダウンじゃないですか。じゃあ残り時間で。¿Hablan español? Yo soy mexicana.
あ、いい。ケンさん、1500円払ってます？
あ、払ってないです。
今出せます。
あ、ちょっと今大丈夫です。ちょっと用意したい。持ってきましたけど、コネクトを忘れて。これ、右に消えましたよね。
小野さん、小野さん、小野さん。小野さん。ここちょっと短くて、そうそうそうそう。なさそうな気がします。
画面がついてなさそう。あ、てか切れてますよ。
あ、だから短い。
あ、届かない。
うん。だからこれ動かしても大丈夫。
しょうがないです。
大丈夫ですか？
画面的には大丈夫。
画面的にはかぶっちゃうんですよね。
こういう風にすればいいかな。
大丈夫？もうね、OK です。 マイク？後ろマイクがその箱に入ってるんで。後ろのそのコードの横。
Okay, let's get started. First, Professor Susumu Goto, who is the Vice Director of DBCRS, will give welcome remarks.
Good morning, and welcome to BRA 6, and thank you for attending, thank you for coming to Japan and this BRA. Under this severe situation for the novel coronavirus outbreak, actually we couldn't have a few people couldn't come to Japan, but so we are very appreciate your attendance for this workshop. And the BRA is one of the most important international collaborations for our center, DBCRS, in addition to the Biohackathon. And I see more and more field of applications in this BRA, not only for the biomedical applications, but also for the agricultural breeding science, or social media, or even the material informatics. Actually, I attended the advisory board for the material informatics in Japan yesterday, and I see a lot of efforts to establish the extraction method for extraction of the named entity, in this case, of polymer information on the properties of that polymer and the relationship, and also the process which produce the product of the polymer, useful polymers. So this kind of activity, like a BRA, is very important for us too, and I'm looking forward to hear the recent advancement of this activity in the symposium. So again, thank you for attending this BRA, and I hope you will enjoy the symposium and the hackathon in the rest of this week. Thank you.
Thank you very much. And I'm Jin-Dong Kim. It's very nice to meet you again, some of you. So it's sixth organization of BRA. So we are hoping kind of important institutions in Japan which are relevant to our community. The first BRA was held in DBCRS, Kashiwa, and second one was in Ito, where National Institute of Genetics is located. And there was a spin-off in Munich during Oktoberfest. And BRA 3 was in National Institute of Informatics. So then fourth and fifth one was in DBCRS again. And this year in JST. JST is one of the biggest funding sources of science in Japan. And I'm actually reusing this slide many times, but actually this BRA is all about improving reusability of your resources. So maybe I can be excused reusing these slides. So this elephant is, maybe you can think it's maybe entire PubMed, and we would like to know what it is. And And there are many text mining projects which are touching only small portion of the entire elephant. But if we can link all of them, maybe we can improve the chance to figure out what the elephant really is. That's the motivation of BLA. And so the resources we have integrated, the amount is increasing. So for example, this slide shows the number of annotation data sets that have been contributed to this pub annotation platform. So far there are 40 manual annotation data sets which are in production level, so released, and automatic annotation data sets. And in total, there are nearly 300. Actually, there are much more because this slide only shows some freely available ones, and there are also private projects. And in this little statistics among the entire, actually this statistics is extracted from only manual annotated data set, and the mostly frequent tags are protein, small letter protein, noun phrase, protein molecule, sentence, cell type, other name. So these are a little bit messy because those semantic tags are not yet very taken care of. So cleaning it up and improving semantic linkage of those tags would be remaining work we have to be involved. And this is recent our work to kind of give an overview of the data sets stored in pub annotation. So based on the mesh terms, for example, these annotation data sets in pub annotation belongs to organisms categories. So now currently this screen shows only the top level categories of mesh terms. And these projects have annotations that belongs to chemicals and the drugs category. And if we want to look okay, it was not the real one. So this is the real service. Among those projects that belong to chemicals and drugs category, you can break down. So this kind of interface will improve the accessibility of those annotations. And also, we have been integrating annotation, automatic annotation tools. So far, 33 annotation automatic tools have been integrated or linked to pub annotation. So, for example, this one is a product by University of Manchester, and it gives you annotation on the fly, discourse analysis, and for example, this one is serviced by Fabio. This is Ontogene ER. This one also produces. It's actually very nice annotation. This annotation on the fly. So it means believe those communities, users of ontogene ER and users of Power Notation are kind of interlinked through these tools. So it's kind of linking of two communities or different resources. And there are actually many more. And last time we could publish a special issue through this Journal of Genomics and Informatics. It is an open access journal, and all the full papers are immediately included in PMC, and article processing charge is free, and it also provides a free English proofreading. And we could publish it 2 mini reviews and 7 application notes. And this year, we set this social media mining as the special theme of PLA 6. And in our program, we have 2 keynote speakers and 2 invited talks and 13 proposals of projects that will be, for that we will collaborate during the 3-day hackathon from tomorrow. Unfortunately, the speakers of 2 proposals canceled their travel due to the outbreak of the coronavirus. But hopefully, I hope they can join us later. And in this symposium program, because we have social media mining as our special theme of this year, 2 keynote speakers and 1 invited talk are specialized to social media. And the first session is dedicated to social media mining. And I hope you enjoy today's program and following 3-day hackathon. Thank you very much.
Right, so Jindong has asked me to chair the first session. I'm Fabio Rinaldi from IAI Lab in Lugano, Switzerland, and also former University of Zurich. And it's my pleasure to introduce Graciela Gonzalez here. Graciela is originally from Mexico, but she spent all her professional life in the US. Actually, if I remember correctly, she told me once that she even went to school in the US, just crossing the border every day. So she was living just across the border from Mexico to the US, when the border was a bit more open than now. So Graciela spent 11 years at the University of Arizona State University, in the medical informatics, and during this year she developed many interesting applications in medical informatics, traditional NLP medical informatics, and recently in particular very interesting work in social media mining. Now she's at Penn University, and
Penn State is often confused with it.
Sorry,
University of Pennsylvania.
Apologize. From America.
I know, it's a common mix-up, don't worry.
So Graciela, please come. So you free me from embarrassment. Thank you, Graciela, for coming.
Those are totally common mix-ups. Both the Arizona State University and University of Arizona, the only 2 universities in the state of Arizona, so they're often mixed up. Mine was Arizona State University, and University of Pennsylvania is in Philadelphia. It is not a state university; it's a private university. So Penn State is the official other university in the state. Anyway, big mix-ups. Which brings me, I actually have a little bio that was published by my department. They found my story on the ups and downs and all that life story interesting, I guess, and so they did a really nice write-up of it. If you're curious, that tiny URL there has that story about crossing the border. It's like one of those I tell my PhD students. I had to bike across the border 40 minutes to get to class to get my PhD. It was true. It's just at the time I didn't pay attention to it. So it's kind of like those stories that sound more interesting once you tell them after a few years. There was even an attempt to recreate my bike route by some of my students. I advise against because the city has changed from the time when I did it to now. So anyhow, so thank you for having me. It's really a pleasure to come here after I was here on BLA 2. This is my next one after that. And I have today, I was kind of happy that they chose this topic. It's on the ethics of using social media data for health research. I gave them 2 topics to choose from. They chose this one. It's particularly dear to my heart because that's the #1 question I get every single time I present on our social media work. This is where the questions come from. So I hope that we can have some time for discussion towards the end of my allotted time. Otherwise, I'm going to be here today and tomorrow, full day and half day, and I'm always open to discussing and answering questions out of the experience that we've had. This is my work in social media has been funded for 8 years. I was just talking to someone along the way about it. As far as I know, it is the first R01 granted by the National Institutes of Health on social media research. So I've been working at this, and prior to that, it was 3 more years. When we started this research, it was 3 years ahead of when I finally got funding for it. So it took a long time. Twitter to me is a really good communication media. So not only do I do research in social media, I do believe it has its role in research and academic life. So I put my Twitter handle. Obviously, email also works. So let's start by thinking, who uses social media? And these days, actually, the question should be, who doesn't use social media? Social media has become ever present in all circles, in all ages. This graph shows over the years the percentage of United States adults who use at least one social media by age bracket. The top line is the youngest, 18 to 29-year-olds. But if you look at the bottom line, those are 65 years and older. That, when at the beginning it was very common for them not to use it, you see it has spiked up. So now we get about 30% of the adults 65 years and older use social media, and that's gonna tend to grow as we age. So it's gonna just keep growing. And the youngest bracket, 18 to 29-year-olds, were all the way up to 80%, 85%, and I will contend that it's even more. This is based on Pew Research data. So overall, 79% of the U.S. population as a whole uses social media, one or another of the social media outlets. Worldwide is estimated at 45%. This is data from Statista. The other one is from Pew Research. Again, it depends which one. I've always get also the questions about Twitter versus Facebook versus Instagram versus others. It's going to vary. It varies in Europe versus Asia versus Africa, Latin America, and so on. Regardless, in most countries, I think except China, we can find easily accessible social media data that we can use on Twitter. I think the next question will be around how long do people spend on social media? Right now, the estimate is about 3 hours a day, which is incredibly high. 3 hours of a day of everybody, probably in this room, is spent on reading social media posts, posting, writing, replying, looking at it. And yeah, everybody's going to say, no, I just took half an hour. I don't think so. So the significance of this is the amount and variety of data we can get from social media is just tremendous. It's not to be ignored. It has its pros and cons. So Twitter data for health research. On the upside, large volume of user-generated text. Tweets are publicly available to view and use. Actually, we'll get more into it. That's exactly the topic of the talk today. they have specific characteristics depending on whether you go with Twitter, Instagram, or Facebook style, or Reddit. They have different characteristics. Part of my background is in communications, pure communications, like newspaper style communications. I have a minor in journalism. And one of the things we learn is that the media is important. You cannot just take all of them flat and use them, because their purpose and model is different. The model of communication in each of these platforms is different. So I might or might not get into that a little more. But basically for Twitter, I prefer it myself because of its specific characteristics as a communication media. So it is more like a journal where people tweet about their lives and you can like distinguish the temporal nature of it, versus, for example, let's go to the extremes like Reddit, where you post about your interests, and there's no necessarily a timeline associated with it. Even if you were to take all the posts that somebody made on Reddit, it's not the same as a Twitter timeline. Okay, so the timeline, temporal, longitudinal nature is very, very important for health research. Twitter provides an application programming interface, API, which is very straightforward in following the rules. It is really easy to use. It is made for this kind of stuff. Facebook doesn't, and again, each of these things will give us like enough material to talk for hours, I guess. So Facebook is different in that respect. Instagram is different in that respect. The API is not very easy. It's not really easy to collect data. Even Reddit doesn't make it easy. So Twitter, to me, is the entry point, and is the easiest one, the most transparent, for ethical research. Actually, is the easiest one to grab onto, for different reasons, particularly because of the clarity of purpose that is very well communicated to people, users of the platform. Still has many downsides. Using social media for health research is unstructured free text, which to me is an upside. Every time that everybody tells me, it's like, well, it's all structured, like, boring data. Unstructured data to me is much more fun. So it's not exactly a con, but anyway, it represents downside in terms of the methods you use and so on, but all are challenges that are addressable. It is contended to be mostly noise. So one of the challenges as researchers is to how to get to the actual signal and not just noise. Informal language and misspellings, and I mean, in my view, that's again something to just deal with, and it actually has meaning. You need to get your end-to-end processing pipelines in place to properly use the data in research and systematically use the data in research. One of the other downsides, I guess, is that people fail to see this, and that they take the tasks in isolation and then decide to publish on one of the tasks in the pipeline, say, and take the data, massage it, balance it, and do all kinds of things with it, and then do a task, and then publish a paper. And there's many papers published like that, don't get me wrong. They are just not right in a way, and actually not right, period, because they are, it's useless to publish, say, on just to give a concrete example, adverse drug reactions. Some of you might be familiar with that, a paper that was published on adverse drug reactions using the data we published. And it was done in what I consider improper way, where they rebalanced the data, got rid of all the negative examples, got 95% positive examples only, and then proceeded to train a model on that for adverse drug reaction extraction. The model then was published saying this is state-of-the-art performance. And so we published a whole editorial that is, I think, the longest one that was allowed at JAMIA, because we exceeded it by twice. Instead of 1,500 words, we were allowed 3,000 words. It's almost a paper, actually. But it had to be done as a comment to that paper, because there were already 6 or 7 papers citing that paper using the data in the same incorrect way. So anyway, so read that. It's an interesting read. So end-to-end processing pipelines are not easy to construct, and usually are underestimated. The amount of work that it takes to do one of those pipelines is usually underestimated in grants, and therefore people don't get the funding for this thing. So this R01 has been continuously funded for 8 years now, this shows the last 3 years of work past the renewal point. This is a longitudinal study from social media. I'm showing the whole pipeline. We have work pretty much in every single one of these steps, getting the data from the Twitter API, how to get the right keywords to get it. For example, it's a paper on its own. And I have like 2 different ways of getting these keywords. We have generating misspellings, which was kind of a funny thing to do back in the time, because usually you get spell correction. You don't get the other way around. There was no system that will generate misspellings for us. So we did one misspelling approach to get how people will tweet about medications, for example. Medications are hard to write, and so they will tweet them with different with misspellings. And in order to collect the data, you need to get these ones up front. So we did that using phonemes. So people will think of sounds when they hear Xanax. They will either spell it with X or with a Z or with many other ways. And many of the misspellings actually were more popular than the original spelling. So we got that. Moving along. In this case, for our renewal, we were focusing on pregnancy. So getting who's pregnant from social media, initial approach is basically on pregnancy announcements. So we were trying to capture pregnancy announcements of many different kinds. We discovered that about 18 of these expressions gave us a lot of content. We've grown that a little bit more. And pregnancy announcements, I mean when I say we're having a baby, I'm 14 weeks along in my pregnancy, and so on, and we're going to be 4, family of 4. So there's many ways in which pregnancies are announced. We've added more pregnancy announcements through a negative outcome, for example, address a few of the holes we had at the beginning. Miscarriage, for example. Many women miscarried before they got a chance to announce, because there's this cultural norm, at least in the US, to not announce your pregnancy until you're like 12 weeks along. So what happens is many lost the baby before they got a chance to announce the pregnancy, and we were missing that, or data set was biased, and we were not capturing that, and now we have corrected that. So along the way, just finding the right cohort is tricky. Birth defects. So after that, we focus on studying birth defects. Again, the whole development of the birth defects approach. How do we get the cases for that? Took about 6 to 9 months of work, just getting the right regular expressions, the right vocabulary, variants of it, how are birth defects expressed in social media, and so on. So each of these steps, I said, it takes time. So we got that published. I have a few of the citations in the slide at the bottom. The very first paper on pregnancy cohort was in the JMIR journal. Main author was Abid Sarkar. And then we had follow-ups on that. We have birth defects. The main author on that one is Ari Klein from my lab as well. And then the latest on that is on Nature Digital Medicine. So we've moved along the spectrum of journals. This is serious research. It's starting to be taken seriously. Therefore, the ethics become even more important as you move along. Finding control groups. So here's just examples of these pregnancies. So we have a timeline. So this date at the beginning, it says, I woke up today with a sore throat and stiff neck and feel even worse now. Advil bed, I hate viruses. That's the first tweet that you see here. The date is prior to the announcement. Okay, so the announcement of pregnancy is in July. This is in the same year. This is February 11. This is July 11. It's time to announce that I'm having a baby and it's going to be a boy. And then November, well, today's my due date. So with the due date, we calculated back to the beginning of pregnancy and can get the pregnancy period. So that first tweet can indicate that this woman took Advil ahead of even knowing that she was pregnant. Finally, they got the birth of their son, and then this is what we got for the birth defect. It's called Hirschsprung's disease. Um, so, full spectrum, full story of this particular pregnancy. To capture that takes quite a few of these steps. We have medication mentions. We have how to get a control group. And then the mention is not enough. We need to know if they took or if they're likely to have taken the medication. So medication intake is another one of those papers we publish on classification and looking at that and so on. Medication mention is a recent paper by Davey Weisenbacher, who is here today. It's a paper on that, on how to get the actual mentions of medications from the pipeline. And finally, to a case control study. We publish in Drug Safety a case control study, nested case control study based entirely on social media. And one of the things that was key, and that paper that we published in Drug Safety had a very loose definition of a control, where there was no evidence that a birth defect had occurred. We took it to be a normal pregnancy. Yes, it is very, very broad, right? So I criticized it myself, went ahead and designed something better. At the time, we annotated around 400 timelines. It takes about an average of 2 to 3 hours to annotate each user timeline. A lot of work. So 400 timelines times 3 hours, that's about 1,200 hours of annotation just to get that very first drug safety paper. So yes, when people tell me, like, why didn't you do 4 controls per case? It's like a lot more time will be needed, which through the years we've started to dedicate more time to it. This is an automatic approach. It is going to be presented at the AMIA Joint Summits in March. So you got a preview of it. This is work that will be then shown there. Basically, we're doing better controls. Is one of the aims of my grant was actually how to get controls. It's harder than cases, believe it or not. So normal controls are hard to get. We get dual expressions. We get, in this case, if is the length of the pregnancy, is came to term, and the weight of the baby. And we needed expressions for both in order to qualify for the same pregnancy. That's the other trick. We have multiple pregnancies sometimes in a single timeline. So we checked for all that and finally got our users to be a negative or a positive for a comparison group. So even though each of the expressions could be positive for, say, for example, I'm 38 weeks pregnant, I've never been this pregnant, it is positive for being term birth, but for that same user, if we have, this is a different pregnancy actually, a whole year of difference in the dates of the twins. So even that both of our traps of regular expressions got a hit, one of the hits was for another pregnancy. And so it takes some doing. So where does that give you? So I gave you an example. As I said, it's 3 years of research summarized in about, 10, 15 minutes. The ethical question, ethical quandary. We're going to have all this inclination to say, well, the data is publicly available. You can reach underserved populations and bring their voice to the table. Social media makes research feasible and low cost, so it must be a good thing. It's unfiltered data, so you can get what patients really think. And it's a simple question, okay? You can dismiss it all up front and say, oh yeah, it's a simple question. It's, of course it's ethical. So it has all these good things going for it. But beware, okay? Even though this might be true, ignoring the other side of the coin could be dangerous. So that's why we get a little nod to Japan right there. But just because you guys are the first audience on this particular talk. You have to consider the counterpoint, okay? The data can be traced back to specific people. Using the data willy-nilly could possibly result in harm to this individual, depending on what topic you're dealing with. Once we do research, we're taking it out of context. People might have said something, but they didn't mean for it to be used in a public forum, okay? So things about mental health, things about illegal substance use, about risky sexual behavior. All of those things are delicate topics. We cannot just take a tweet, put it up on a slide, and show it in a room, because you really never know who's going to see that slide. So it could result in harm. Question yourself, is it really publicly available? I've seen papers published where upfront they say, we created 10 fake accounts, joined the private group, and collected the data. It's like it is published. You can find this paper. I'm like, okay, I don't, on purpose, I don't put that up, but you can look it up. Okay, just the word there, fake users. We created fake users and put them there. That's already deceiving. Okay, so some of your warning lights should come up with this, and sirens sound in your office when you're doing these things. Okay. It is difficult to determine what risk and privacy expectations are unique to social media. It's not a simple question. So you have to stop and think when you design these studies and try to determine what you're doing. Black and white can quickly turn into gray. It's complicated. It's not easy. And you have to think about these things when you're doing research on this. So first question, is it human subjects research? And from all the questions, probably this is the easiest one to answer in a way. So who is a human subject? There's a definition for that. I'm using United States federal definitions for this. It varies by country, but in general is widely accepted worldwide. So a human subject for purposes of health research and research is a living individual about whom an investigator obtains data through interaction with the individual or through identifiable private information. The or gets us, okay? Even though we're not directly contacting them, we might still fall under this. So let's think about this identifiable private business. So data is public if information can be identifiable, but is not private. Information, so data can still be public. Information can still be identifiable, but it will be, if you get into not private and you have the definition of not private down, you will be fine, and we'll get more into it. And information gathering requires no interaction with the person who posted it. So what does this mean in practice? Who determines this first, and then we'll go into what it means in practice. You will have to submit all of this to your institutional review board. Different names, different countries, but it's basically whoever oversees research in your company or your academic institution. You need to submit your research to them. The research activities involving human subjects are limited to one or more of the exempt categories receive what is called an exempt determination. All my research is covered by this. So I have an exempt determination certificate from my IRB, Institutional Review Board. So anything that you see published is covered. So that was like every time I get the question, I say, yes, it is. It was exempt. It has an exempt determination. It is usually the one that's applicable for social media data is called the 45 CFR 46.1. So if you know this, you probably, if you've heard this and you know this, that's usually what you use as an exempt category. It's an exemption that covers existing data, document records, and specimens. It applies to that. If you use existing data, then you're fine. So we'll see a little bit more of how this applies in practice. Okay, so bear with me for a second. One question that is usually not asked. Ethics and morals are often confused. So these things that we do with social media are covered under ethics. Okay, you might have some other moral quandaries on this, but those are usually more private, more personal than ethics. So ethics are agreed upon principles of right conduct. They vary by discipline. There's like usually professional associations that publish these ethical guidelines for researchers. They apply to institutions that conduct research, whether in academia or industry, so both have it. They are less subjective and less personal than moral behavior, okay? Personally, I will add moral behavior to my ethical behavior, but ethical behavior is a little bit less arguable in its inclinations than what we call moral behavior. Some groups that have established relevant principles include the American Public Health Association. Obviously, this has the U.S. bias. I have to look up the World Health Organization has some guidelines, and there will be some guidelines in each of your countries as well. The American Medical Informatics Association has another one. The Association of Internet Researchers is a little bit less American, but still, I mean, it applies. They have all published these ethical principles. In general, ethical principles in health focus around the policy of do no harm. Okay? Your subjects are protected by that overarching question that if you're harming them, research is not an excuse to harm anyone. So in practice, what does this all mean? Well, use only data available to all users of a platform. It used to be that some institutions will say if you have to use a user ID and password, then it's off limits. But, I mean, for example, to get Twitter data, you need a developer's ID and password. So that's an ID and password. That will mean all of Twitter will be out of the question. So many of these little rules are outdated already. But in general, use only data available to all users of the platform. Okay, that's an easier definition to abide by. Private groups are off limits. Okay, there's a whole paper, main author by Suwalder, I have it in the references, that they actually went and found out what people think about this, how they feel about it, and so on. One of the things that is important is private groups. Private groups are considered by people private, meaning if you have to join a group that shares something. I have several private groups that I've joined, and I've seen information there that I wish I could use in my research, but I couldn't use it without first telling the group that if they are okay for me to use that information. And in that case, I'm contacting them, and therefore it's no longer an observational study. It's going to be considered some like a clinical trial. It will fall under those rules. So in essence, I cannot use it. So getting these fake accounts, joining private groups, definitely not within the bounds of ethical research. And then there's the expectations of the people there. And you will often see, I don't know, I bet most of you have some of these private groups or have seen them or have used them. Most of the people that will say things that you will say, well, they like complain about family members, not understanding their particular situation. So it could really get them socially affected if the information were to get out. No, I don't do that myself, but some people do, right? It's like say things there that you think are not going to get out is dangerous because they sometimes will get out. Screenshots of deleted tweets. Again, it's not ethical to use them, okay? Deleted tweets are gone. And that's a whole other problem in practice for some of the things that I'm talking about here. So we'll deal with that in a second about reproducibility. So private groups are off limits. Having an exempt determination doesn't mean you're exempt of all laws, okay? You're not exempt from local laws. There could be some local laws that apply to it, so be aware of that, state laws in the US or any other regional, that every other regional institution or government agency that has influence or can legally go after you in a way. Institutional policies will usually cover you or ethical research. So that's why it is very, very important to submit to your IRB. That's sort of your layer of protection. Okay, so you submit what you're doing to your IRB. They know better if there's local laws or so on that apply. So you should be always wary of this. My very, very first study, must confess, got me in trouble with my IRB because I did not submit it to IRB. Very, very first one, it was a class project. This is how all this got started. It was a class project. The student wanted to do research. He wanted to do what people talk about their disease. And I thought that was very broad. And I suggested the thing about adverse drug reactions to him. It's like, let's focus on specific things rather than like all these broad topics. Anyway, so that was the start of it. He did his research. It was pretty cool, and we decided to submit it, and it was actually published as a workshop paper at BioNLP in Switzerland, actually. 2007 must have been. That was the very first paper in happened to be, and this is traceable, there's no other paper before that one on adverse drug reactions from social media. Of course, I didn't know that at the time, I just published the paper, so it's one of those. And so we published, and by virtue of publishing, it's a whole issue with IRB. I got funding. The IRB obviously was submitted because of that, and they found out about the paper, and they got at me, and I didn't know better, and so this is one of those lessons learned. What happened was we could not use that data. The IRB said, since that data was collected without IRB approval, you can no longer use it. So all the data for that paper has been banned from further use, and we never used it again. And so that paper is historical for those two reasons. So I will say, most of all, none of your studies will ever accept you from common sense, okay? So you know common sense is a precious commodity. You just have to be constantly questioning yourself about what you're doing and how you're doing it. What are good common sense measures? Just to give you some guidelines on this, not leave you all alone on the common sense issue. Ask yourself, could revealing the information out of context result in harm either now or later? We have a case exactly like this. We were studying the birth defects, and we found a tweet in one of these timelines about illegal substance use. Oh, actually, it was not illegal, but anyway, it's just smoking during pregnancy, which is a general no-no. So what she said was, I'm tired of this. I'm out here in my truck chain smoking. And so we saw the tweet. It was in a paper, in the original draft of the paper. Before we submitted it, I was looking through it, and like, this tweet seems too specific. We searched for it, and lo and behold, I get a single person in the whole wide world that has that tweet. So, so at that point, I said, no, this is not something I want to do, because women that have a baby with birth defects, and I count myself as one of them, face a lot of lashback from family. There's always these innocent questions about, well, what did you do during pregnancy? It's like, I didn't do anything, okay? It's very, very, very hard to face those questions from family members, even from their husbands, not mine. Mine was okay with it. But from family, definitely I got this. Sometimes it's just out of ignorance about the condition. It's out of many reasons. Anyway, we don't want any more spotlight on these women about things they might have done, and it might be, who knows? We don't know. The etiology of birth defects is very, it's missing, it's unknown. The reason for these birth defects is unknown in many cases. So either now or later, meaning don't do it. Limit the specific social media posts used as examples in a scientific paper for the same reason, okay? So you can use some examples, but limit the use as much as possible. And if it's a delicate topic, mental health, illicit substance use, even substance use of any kind, sexually risky behavior, do not publish a post verbatim. Try it. Go to Twitter, see if you can find it again. Things like that. Modify the language enough so that it's not, you can literally not find it once you and it's incredible how short those of us in NLP know that 4 words can get you a very narrow one result very, very quickly. Okay, so it's incredible how unique language is in that sense. Platforms like Reddit that are built around anonymity kind of have the protection already, so you don't need to worry about those. Even if they went to the platform and they found it, it's anonymous, so you're good. Okay, so many times for that reason, Reddit is a good platform to play with when you're doing risky, delicate topics. The other practical approach in common sense measure, just use aggregate data whenever possible. So talk about 5% of people talk about the anxiety that it gives them to, like, whatever, consider this. So you have percentages and counts rather than specific examples. It's actually, scientifically speaking, a better approach, actually, because I call them the social media equivalent of N of 1, are this, we found 200 tweets, and they all say that the HPV vaccine kills people. Like, we can find pretty much anything in social media, okay? If I say it's gonna cause the apocalypse, you probably can find that. It is just that, it's an opinion, it's an N of 1, okay, even if it's 200 of them. Without context, it means nothing, okay? So it's better to just get everything about the HPV vaccine or whatever it is that you're researching on, and then do a systematic analysis of the tweets to try to see what percentage of people believe whatever it is that you're after, okay? So it takes a long time. Again, I go back to how much time it takes to annotate a timeline, and you'll see that these things are not easy to do. Social media research is not easy to do. So some of these are like common sense measures. I call them common sense measures. Which brings me to reproducibility. Data collected ethically from social media for research must be made available if at all possible. You cannot hide behind this like excuse saying, oh, it's social media, we're protecting our subjects and this and that. That's why we're not making available our data. That's not acceptable. It's not acceptable science because there's rules. That's why there are rules for these things. Twitter, for example, allows you to make available all the Twitter handles openly. So we could make those available. There's a limit on the number. So there's only 50,000 a day per user. So if I have a collection of 200,000 tweets, I can only give you 50,000 at a time, 50,000 per day. So there's like silly rules like that. I call it like, well, fine. But you abide by them. You abide by the platform terms of use. You abide by those rules, but you make them available. What happens with this rule is many of the tweets are deleted. Therefore, when I hand you my data, if I use 50,000 at the time, and by the time I give you the Twitter IDs, 20% of those will be gone. So that's a problem from the reproducibility perspective. What we do in that case, we keep a copy of the actual text of the tweets. And that requires a little bit more layering. So I don't just hand it out to everybody. You have to write to us, say, hey, do you have the full data set? And we always do in the recent research. Don't ask me about things about 8 years ago, okay? So I already talked about that. So recent research, and I give like a ballpark of 3-4 years. After that, things happen, okay? Hopefully, my hope is I can get it extended to 10 years, that you can get a paper of mine 10 years ago and still have the whole thing done so you can reproduce the research. The reason it's not necessary to go that long, though, is because there's always papers that follow up, right? And so one paper builds on the prior one. If that was reproduced and it was done properly, then the next results stand. And all you need to do is to compare to that newer paper in order to move forward. So you only need to keep this going for about 3 years. So that's kind of like my ballpark. When you publish, share your code and data and maintain it for at least 3 years. That way you can ensure that it's properly used and reproduced. Good science is reproducible, okay? So you have to do good science in order to maintain the reputability, in a way, of social media as a valid data set. A lot of the bad rep that it has gotten is because of bad research, okay? It's not really the fault of the media. It's just the fault of the researcher. And I include in that the Facebook Cambridge Analytica scandal of a year ago or 2 years ago. I don't blame Facebook. My idea of it, the blame is on the faculty member at Cambridge that started this all and didn't think through. He saw the cookies on the counter and he decided to eat them, okay? And it's not always okay to do that. He got a consent to get one user, and those users had friends, and the data of the friends was available to the to the wall of the user, the original user, and he decided to go ahead and use that data as well, for which he did not have consent or that access to the friend's account. That was the core of the problem. That the Facebook software allowed it was why Facebook got blamed. But there's always going to be allowances. There's always, I mean, how many of you are developers? Like, that have written code. When you have written code, you realize, that's what I mean. When you realize there's many ways around things. There's so many ways. There's always going to be a way. Data cannot be locked up in like 5 different locks. It's very hard to get that level of assurance. So just do the right thing and don't use it. That's the thing where we go with the ethical thing. Reproducibility requires research integrity, open data, open code, version control. I'm borrowing this slide from someone, so you don't think that it's all my idea of things. This is not my slide. Data secrecy is very, very close to scientific misconduct. And it goes to the point where it's actually like anything that's published that you cannot reproduce, to me that paper should be ignored and not even cited. Okay? Because it's just not, I mean, whatever it is like, how will you know that it's true if nobody can reproduce what the findings were? So there's a spectrum, and we try to keep our research on the green there. Okay, some of the references that I cited. These 3 are the strongest. I wrote a blog by invitation of the NLM's director, Patty Brennan, on this particular topic. It came out about 7 months ago. You can still find it, Musings of the Mezzanine. It was an invited blog. And I have all these citations there and others, if you're really curious about it. There's a lot that has been done, a lot that has been learned, and I really, really encourage you to, like, whenever you're considering social media research, to abide by some of these guidelines, and it should be fine. It should be fun, and it should be meaningful. Okay, and that concludes. I have a little bit of time for questions, so thank you so much. Kevin.
You've been talking about ethics related to the data itself. Can you talk about ethics related to what people do with what data classifiers? So my question is about the issue not of ethics of data that you've been talking about, but ethics of the use that people do with what we build from the data. For example, from work that you and me have done together, I have run into people who had 2 nightmare scenarios of what they could do with our work. Could you talk about what your thoughts about our responsibility for the use of our research?
Okay, I think there are some limits. There's always going to be evil. There's always going to be misuse. Think the atomic bomb, which I think should be pretty sensitive in this particular reason. So research from those scientists was misused. Now, not to compare what they can do with social media data, but it could be very devastating for some people. How much control you have, there's some things that you can do. So for example, making available data openly for anybody to go in and grab, I think is not the best approach. We always have sort of a registration process for example, for the data for our shared tasks. I've instructed, David runs that, and now we have another member of our lab that's running this. Basically, you do not just get the email and send it back. It's like you need, for example, an institution and a supervisor email to be included. So at least 2 people in that place will know about it. Now, mind you, all of these are rules that there's people that are going to find a way to bypass all our care, but at least we try to be as careful. I don't know what else you can do. I mean, there are going to be bad uses of good research in history, throughout history. That has been the case. It doesn't mean you stop researching. It doesn't mean you stop doing it. you just do it responsibly. Now, there's some responsibility that falls back on the user. Not that I want to use that as an excuse, meaning you tweeted about it, okay? So if you wanted it to make it private, tweet about it and protect your account. Twitter gives you that. So we have to be responsible for our actions in social media. It's not all on us. It's not all on researchers. We do what we can, but some of it falls back on the user. So I can argue even that if I tweeted about something, I want to be recognized for that. It's my mini publication. So if I say something, usually people that like the likes, right? And don't you feel sad when like there's no likes on your little tweet that you just did? It's like you want the likes, you want the retweets. And so these mini publications are created to communicate. So we cannot patronize the users and overprotect them and say this person didn't mean to say this. Like, how do you know? They mean to say it. Okay, so the things that people come out with are kind of incredible now. So those are like random thoughts on that question. Other questions?
Because you like to ask something about the
Sure.
organization of the social media health challenge. I was one of the participants. And
Uh-huh.
it was a very enjoyable event. It's an opportunity for all people who work with social media to perform a task and share the results. Could you comment something about
Oh,
the
sure.
organization?
Sure, we have the Social Media Mining for Health workshop. It is in its 5th iteration. It's running this year at Calling in Barcelona in September. The share tasks are out. There's another share task also available through the BioNLP. So I finally made it to my home platform for share tasks. That's how I got started actually at BioNLP, the second BioNLP. I mean, not sorry, BioNLP, sorry, BioCreative. In BioCreative has shared tasks. So we have one running on that as well. This iteration of BioCreative is also going to be in Barcelona. So it seems like we're moving to Barcelona all of September. So beginning of September is BioCreative. End of September is our Social Media Mining for Health workshop. We make available these data sets, annotated data sets that are, as I said before, very expensive to annotate. We're doing this. We have a multilingual data set this year for binary classification of adverse drug reactions that has been done as a team, actually. So people at the Social Media for Health in Florence last year at ACL suggested that we go with multi-language corpora. And I said, well, fine, if you guys are willing to put some work into this. And some people said yes and went ahead and put the work in it. So I have Martin Kralinger doing Spanish. I had to supplement that with my own in-house annotators. Then Elena Tutubalina from Russia, also, so it's going to be Russian, Spanish, English, and French. So we also have a French team annotating on that. Anyway, so we have that. We have a whole pipeline approach. So it's classification, ADR extraction, and normalization, all running as a pipeline. So you have to get all the stuff in order to actually get good results. I believe in sharing a lot of this, and so we have it as a principle to always share our code, share our data, so that others can advance. And it's actually those of you writing grants, that's a very good approach to actually move along in grants. One of the things I said to get to my renewal, the first time I tried, it was rejected the first time. And so they said, basically, didn't you do this already? But I was doing normalization. And I did a very basic approach in my first cycle, so I was all excited, put my newest, greatest plans on that second grant. Reviewers didn't care. They're like, you said you did that last time. I'm like, okay, fine, did that. Forget it. I'm not doing it. So the best way to keep going is make it a shared task. So basically, I work at something, we work at something, make it available as a shared task, and so other people can work on that problem, and I can move on and work on the next problem. So that's sort of the philosophy of the shared task, and I hope we keep going with that. Okay, you're welcome. Thank you so much.
Thank you. Now I have to introduce the next speaker, Stefano Brenzi. we will present one of the projects. So then we have projects that are open to participants to join during the course of the week, the Friday. So Stefano will.
Hi, good morning, everybody. Hello, everybody. Good morning. My name is Stefano. Some people call me Steph. I'm a research engineer in the bioengineering department at Stanford, and also in the Department of Surgery at UC San Francisco. So I'm very happy to be here this morning talking to you all about real-world data. So real-world data is very fashionable right now. We live in the era of big data, where we're continually collecting all this information and building these very large data sets. And then new laws, at least in the US, like the 21st Century Cures Act, are also driving adoption of real-world data and real-world evidence in decision-making processes, not just in regulation, but also you see it in quality improvement initiatives in hospitals, and also in investment decisions in industry. And so to define real-world data a little bit, real-world data is very broad. It's basically observations that are captured outside of the context of clinical trials. So some of the sources that people think about when they talk about real-world data are things like case reports that are published in the literature that's been around for a while. Something that's developing and being implemented right now is electronic health record data and patient registries. And then social media is also another case of real-world data that's probably a little bit more experimental right now. So real-world data, a lot of people think about it in the post-market setting, but it is applicable across the lifestyle of drugs and medical devices, so medical products. And here, basically what I'm saying is it can accelerate R&D and also regulatory decision making. So if you think about research and development or early in the life cycle, right, you can use it for things like need identification. So here you're showing an unmet medical need, and that can be generating a hypothesis about what you should build. The other thing you might be doing with that is using it to apply for an IND or an HDE application, where you're basically getting permission to run a study in humans. Then everybody knows about the post-marketing, where you're talking about a phase 4 study and doing post-market surveillance on drugs and medical devices. So, I would say when you're talking about annotation and a lot of the real-world data, drugs and especially molecular biology get a lot of love, and devices are kind of like the unwanted stepchild of the biotech family here. I'm pretty privileged to be able to work in both the space of drugs and also medical devices. My observation is that the state-of-the-art of real-world data for molecular biology and drugs is pretty far ahead of medical devices. And the reason why is basically because a lot of the key information for medical devices is unstructured and unlinked. So an example of how it's unstructured is that something very basic, like the indications for a medical device or the intended use. I have this device, what is it used for? Give me some terms that I can use to look something up, or I can use to do a query in an EHR. There is no data set out there like that. Nothing like a CIDR or something like that for medical devices. And then even where you do have cases where the data is pretty well structured, so here I'm thinking about something like the OpenFDA APIs for medical devices, right? You have a bunch of linked data there, but there it's still all siloed. You can't really connect that to anything and do anything with it, right? So it just kind of sits there in its little silo, just being there, doing regulatory things. So the question I came here with is, can we use some of the annotation tools here to basically start structuring some of this medical device data, in particular linking devices and indications, and how transferable are those methods going to be? So I have a sense that the answer to that question is, all of the above of yes, no, and maybe so. I think in some cases it might work seamlessly, in others maybe not so. I think there are a few challenges that can make it difficult to do some of the annotation here. So first, the medical devices ecosystem is very large and complex. This pie chart is showing you the number of drug products on the market versus the number of medical device products on the market, and there's about an order of magnitude difference. Second, with these indications for medical devices, you can end up with very, very complex inclusion-exclusion criteria. So here you're talking about complex medical histories, demographic variables, and you can get these very oddly specific indications, and then you can have something on the complete opposite end of the spectrum where it's not very specific at all. And then finally, even if you did have something that worked, it would be impossible to tell because there is currently no gold standard set of annotations for medical device indications, and as far as I know, there's no annotation guidelines. So that brings us to what I'm here proposing for the project. So I'll start with the specific aims. Aim 1 is to develop some annotation guidelines for medical device indications. Aim 2 is to produce a small, modest, gold standard set of annotations. So here I'm thinking maybe like 20 to 50 indication statements. Nothing crazy or huge. And then 3, assess the performance of some of these annotation tools.
You look at me like, sorry. Just reading my face.
So, and then I would also like to keep the scope pretty narrow here. There are lots of medical devices out here, so boil it down to high-risk medical devices. These are class 3 devices, so think life-sustaining devices and implants. Generally, the descriptions and the approval statements of these are pretty well written, and you want to get the indications right for these, and you probably care if somebody's using them off-label. So here's an example of what some of the data looks like. This is for an implantable bronchial valve. This is a class 3 device. It's probably annotated quite poorly. I just highlighted some text here to give people a sense of what these look like. This isn't the easiest one. As you can see, I think there's 5 different types of entities in there. It's also not the most complex. It certainly does get harder than this, but I didn't want to show you guys that and scare you off. And finally, the ultimate goals for the project. This is really all about kind of improving the medical device data ecosystem. I think that there's a lot of research out there that could be done and a lot of research that isn't being done because of problems like this. In fact, I know a couple of people who have projects that they just didn't do because something like indications linked to devices is just not out there and is not available. The other thing, of course, would be to engage the biocuration community, especially people who are interested in medical devices. I think this is pretty much the Wild West in greenfield. There's not a lot that I've seen done here, and I think that there's a lot of work to do and a lot of impact to be had here. And then finally, experiment with new annotation tools. I think we all, or most of us, like playing around with new software and seeing what stuff can do. And when I looked at the applications here, I saw that a lot of tools had been done and produced here. And if anybody's working on anything or anybody has anything that can help with this, I'd be very happy to be a tester and to learn how to use your tools. So that is it. There is my email and my Twitter. And I guess I have a minute and a half left, so I will leave that time for questions if anybody has any.
One quick question. The source that you said, the source that you're interested in is what kind of text? You mentioned a few, but like for your proposal.
Oh, so in particular, these are the approval statements of PMA applications. So they have this approval process for high-risk devices called pre-market authorization, I think. I might be getting the acronym wrong. But when these get cleared for marketing, they basically publish this statement of what the decision was. And in the ones where they have the indication, they kind of all follow that form where they say approval for the blah blah, this device is indicated for use in XYZ.
So the purpose of that will be to build sort of like a lexicon or a directory of these devices?
Yeah, so it would be nice to have just a database where you have a device, you have a unique identifier associated with that device or a PMA number associated with it, and then you have some kind of ontological terms that you can query on the other end of that. That would be pretty good.
No interest in social media on this? Meaning people mentioning devices is one of the things that I had in the original grant, and then it got because it was too much. So anyway, so social media, just throwing it up because it might be a simpler step to start with, but I don't know. You might be right.
Yes.
Yeah. Maybe just very quickly.
It was just a comment that there is a class of patents related to medical devices that they also be interested in.
That sounds interesting. Thank you.
Okay, so the next speaker. Move to the next one, which I think is Juan Banda, who is also a similar story, originally from Mexico, I believe. Yeah. And he's going to present his proposal on the toolkit for social media mining.
I hope it will work smoothly. Slides. Download.
There's from there, I think.
Come on.
Can you hear me? Okay. So yeah, so my proposal for this blah, it's a little bit different than what I've peddled the last few years. Of course, whoever has seen me here, I peddle more standardization of other resources. Now I'm taking a little segue on this. This is work done with some of my students. And for those of you who know me, I'm a professor of computer science. I do a lot of hackathons. I've been here 4 times. My research interests are machine learning in terms of relation to weak supervision. So it's a little bit different than what most of people do here with NLP, annotating things, building models. I like to see it a little bit different with weak supervision, meaning using some sort of noisy rules, a lot of data to get to the same point. I've done all of that for EHR, and I'm starting to do it with social media because of some other collaborators that I'm getting, like extracting mobility patterns and networks from tweets and also from dark web. And for those that are a little bit iffy on weak supervision, basically, we all know that getting label training data is expensive. However, using weak supervision, meaning that you have some sort of lower quality labels that are easy to make, either just using dictionaries or using very basic rules. But a lot of data with a lot of these rules, you can actually generalize. Get models to generalize better than very narrow annotations and things. So we can talk about that a lot more later. So in terms of why do we need this social media mining toolkit? Well, like Graciela made the perfect case, there's a lot of research that's starting to move in this direction. Biomedical, computer science, social sciences, public health, all kinds of different fields are getting into this. It obviously has to do with the accessibility of the data. It's a lot more accessible to get a bunch of social media data than patient records or genetic data or anything like that. So the problem is that, everybody's doing it, everybody's doing it differently and in their own way. So when I started getting into this space, I usually download hundreds of papers, read all of them, set up a mental model, and then see, what people are doing. Well, I noticed that, everybody's doing it their own way. There's no standard tools. So there's some tools provided by Twitter that access their API, but if you want to scrape something, if you actually want to, get stuff out of the Twitter JSONs or Reddit data, there's not a real standard toolkit anywhere, right? Or you have very isolated tools, that you have some scraping tools, but they only do that. You'd have not a lot of tools that are available together. And like we all know, the paper's done, software is never shared, or if it's shared, it's like this cryptic Perl script that worked on one, I don't know, Unix computer from the 80s, and that's it, right? Or there's some Python code that I don't even know which version, the code doesn't say that. You try it, doesn't run. It has some ridiculous dependencies, some files named blah.txt that you'll never find. So it's hard to get all this stuff pieced together. In a cautionary tale, I started by asking some students. So we got a data set that somebody from a different department purchased. It was around 500 gigabytes of tweets. And I told these two students I had, one was an honors student, the other one was a PhD student. I said, okay guys, here's a data set. I want to extract this type of tweets from them. You go to town, do whatever you have to do. Well, actually this example is from the Twitter String Graph, sorry. First of all, I told people to go and download the data from here. They were like, fine, got the data. Two different students got two different sets of fields and all the files that you found there. Oh, weird. Okay. Then they also got a vast number of different tweets with requested content. So we were looking for drug-related tweets, and they actually got very different numbers, completely different numbers. Why? Well, one person used actual Spacian, some more NLP-ish tools. The other person just wrote a bunch of regex. So you can see where this is going bad. Why? Well, because we got completely different signals on this, right? And this happened in a lab of 6 people, where the students could actually talk to each other, but they didn't. Imagine what happens when you have all this research going on everywhere in the world with groups that might not like each other, speak different languages. So this is a mess, or at least the way that I see it. And then you ended up having 2 completely different and hard to use code bases. So this guy had a bunch of regex and some bash scripts. The other guy had some nice Python. And again, not great. So what do we propose in this toolkit? So again, we want to have, to begin with, data acquisition tools. So everybody wants to use social media, at least from the requests I get people from public health. Like I said, I get people from other departments saying, oh, I want to use Twitter. I'm like, cool. So where do you download Twitter? I'm like, yeah, it's not really that, right? So in this set of tools, I propose to have Twitter data gathering tool, in the sense that you connect to the pipeline, get some new data coming in. Scraping, I know it's a lot of people don't like doing this, but still, if you want to get a lot of historical data of something, you need to do some scraping. As long as you do it all ethically without creating some fake accounts and doing all this nasty stuff. Hydration tool, this is one of the most common. This is actually the only standard way you usually find people sharing research. They share a bunch of tweet IDs, and then you have to hydrate them. That's, I think, the only standard thing about most people's research and what they share. Collection. Oh, you basically get a tweet ID, and then that goes to the Twitter API and fetches a full tweet. Because according to Twitter's rules, you cannot share the full tweet. You can only share the tweet ID. Yes?
You can share them if it's for research purposes, actually.
Yeah.
So you can share up to 50,000 of them.
There's a lot of, weird on that, things like that. And collection as well, I have, or at least people want to collect this periodically to see trends and things like that. So these tools are, again, I propose these tools. They sound like, oh man, this guy's going to be coding 24/7. No, a lot of these tools are partly done. It just needs to be standardized and plugged in. Pre-processing tools, again, extracting from the Twitter JSON sounds trivial. It's not trivial for somebody from public health that doesn't have, Python and data science skills. Even parsing Reddit files. Some people know how to parse properly HTML, some don't. you use Beautiful Soup or you use regex. Again, all these things to standardize them. Why? Because we want to get the same outputs. And also, we want to provide, some sort of standardization to either dictionaries or ontologies. And we want to provide, dictionary generation tools. That's those are easier ways of people finding things in tweets. And we want to have some sort of manual annotation, backend for people to use. So all of this in one single place, so you don't have to be downloading a bunch of different things from different authors. So again, I mentioned this sounds like a lot, but a lot of these components are created. I have my students worked on this. I just need to basically piece stuff together. Also, some of you guys have probably worked on this, have some cool things, some annotators or any other sort of cool tools. Talk to me and I can put them in here instead of reinventing the wheel. That's the whole point. And also talk to people here about, what would you prefer to be standardized? What would you prefer to see, and how you want it to be done, rather than just a bunch of ad hoc tools that just do things not very standard. So there you go. So thank you for letting me be here again, and I hope to have some interesting conversations and work on this. Questions, concerns? Cool.
Quick question.
Yeah.
Can you talk a bit about how people can vary things in the workflow? For example, you want to know if a result holds up if you tweak some part of speech tag, right, or your token principle.
Mm-hmm.
Can you talk about the trade-off between that and standardization?
Well, yeah, that's actually a pretty interesting question. So once if you don't have access to the part of speech tagger or anything, or even normalization they do, then you can't really replicate what they do. It's nearly impossible. You can try very hard. So at least by having something standard here, that everything is transparent, that you have a version that is versioned, it also goes into being fair, right? Because you'll be able to say, I used this version of this toolkit, I use everything, all the settings, and you can go and try it. At least that should get you closer than everybody using their own ad hoc things. Okay, cool. Thank you.
Use a few extra minutes for moving to the next presenter. Thank you.
Thank 30 seconds.
I think the next one is Debbie. About the share tasks that Graciela mentioned before.
Yes.
Thank you. So hi everyone. So my name is Davy Wesenbacher, but just call me Davy, that's fine. So I'm currently a research associate in the HLP lab in the University of Pennsylvania, working with Graziella. And during the hackathon, what I want to do is starting to write a collective guidelines to help the people organize shared tasks on social media to extract health-related information. So that will be the goal. So since the first MAC's conference, we have seen a large increase of the number of shared tasks that the natural language processing community is organizing. And some of the shared tasks are focused on social media and name entity recognition. So mainly for English. So as we have seen here, the Neil and the Wintnut series and the SMM4H series that we are organizing in UPenn. But also in different language like French for the CAP conference, and this year we were speaking about that in French, Spanish, Russian, and English for this year social media, the SMM4H. What are the advantages of the shared task? So that's pretty obvious. The people create standard data, and then the data are shared so that the people can run their experiments on those data and compare their results without having to rerun obscure software, but they can use that as a baseline and compare their results, and that helps them to improve the reproducibility of their results. The problem with the shared task, when I was starting to write the proposal for BLA, I didn't find a standard guidelines. So what are the questions that the people are facing when they start to organize a shared task? There is no comprehensive list of the problem that you will face when you will start to organize that. So the goal here will be to start to write the first draft of these guidelines that will help the people to take over when they are starting to organize one of them. So the work will be organized that way. During the first 2 days, we will go through the main tools that are involved in the preparation of the shared task, meaning the annotation tools for the first one, and the second one will be the evaluation platform that start to be used. You can do a shared task without any evaluation platform, but we can see more and more the use of Codalab or Kagel's platform, for example. So how to set up them and what they can do for you, that would be the main question. The third day, what I want to do is to speak about the past, going inside the literature and see how the people were organizing the shared task for social media. During these 3 days, we will have round table where we will discuss a list of general questions that we are all facing during the event when we are organizing the event. So this question can be about the annotation process. So a generic question like, how many data do I have to annotate? Do I have to double annotate the data? Do I have to balance my data for annotation or not? And during the main task itself, how do I ensure that the people will be able to reproduce the results that are produced during the shared task? Who can I register? Do I register only academic? Do I register students, normal people, private company? So all these choices has to be made and will impact the results of your shared task. And the end also, the dissemination of the results. How can I help students that for most of the time is their first participation to a shared task to help them to write the paper in order to have a documentation of the system that has been produced? That it's also a very hot topic that I want to address. So during the first day, I come with data. So I come here with 20 timelines that we have annotated in the lab. So for those who are not very familiar with the timeline is just the list of tweets that has been published by a person during a certain period of time. And these timelines have to be annotated, and the annotation can be at the different levels. It can be the phrase level, that can be the tweet level, that can be sequence of the tweet level, that can be the user level, or that can be the network of the user level. So far what we have been using in the lab was Gate, as you can see, but Gate has some limitation. So what I want to do in the first day is to go through the annotation tools that has been reviewed recently by Nevs and Siva, and see if we can find inside this list of tools or ideal tools to annotate social media. So our annotator, Karen O'Connor, already started to screen the tools, but she hasn't finished. So what I want to do is to finish that. And the main point will be to start evaluating the tools with how many tweets they can load and the time that they take to load the tweets. Is it easy to see the tweets and the timeline? Some of the tools is only one tweet, so when you have to annotate sequence of tweets, you cannot do that. So can we have this type of interface? How can we visualize the annotation, the tags themselves? That's also very complicated, very important. Do they support multi-level annotation, phrase, tweets, and so on? With the subcategory, sometimes you want to have subcategory inside the annotation, and also more and more we are starting to normalize the annotation, so that means can we link the annotation to external resources, like MIDRA, RX norm for the drugs, for example? Can we support that and help the annotator for doing that? Can we ideally have the support of the multi-annotation, so seeing automatically the inter-annotator agreement computed and the disagreement? We have also all the science computing question. Is it stable? Can we have the auto-saving? Is it a nightmare to export the annotation that has been filled inside the system? Ideally, we want also to have the possibility to run pre-annotation tools and eventually the support of active learning when we are doing that with a machine. And we want to have that free, because we like free, of course. So free and open source. So that will be the main question. During the second day, as I said, we will start to try to find the evaluation platform. So for SMA4H and SIMEVAL, we were using Togotv, but Togotv is not stable, so we have a big crash 6 months, 8 months ago, and a lot of competition had been lost. So, and there is no documentation. So when you have a bug in Togotv, well, you are on your own, and good luck to find the bugs. So I want to see if there is any other platform that exists. And I want to spend my time on evaluating how easy it is to let the people upload their code and run the code directly on the platform. That will be a main point to ensure the reproducibility. So our previous speaker was speaking about that, the nightmare of reproducing the results. I think that here it's important to see if this type of evaluation platform can do that, but just by running the code directly on the server before the evaluation, so that we are sure that the code is there. The last day, I have already prepared a list of questions, but this list of questions is definitely not exhaustive, so I want to complete this question. And these questions are generic for some of them, so we will not have any answer, but the point is not to answer the generic question. The point is to have those questions and then go inside the literature and see how the people address those questions and see what were their choices. And that's all what we want for this particular event. So during the last day, I want to start the state of the art, basically. Starting running, extracting all the shared tasks that has been run on social media for health, and start to see the generic question that they made the choice and how they address that. The last point will be how do we evaluate our work. At the end of this hackathon, what I want is to have a draft of a collective work that we can extend and finally publish in a journal. So that is all. If you have any question, I'll let you with the beautiful campus of Philadelphia. And take your question. Yep, Kevin.
You mentioned the educational value of shared tasks. What ideas do you have about how to advance that?
Well, so the education point is the fact that some of the participants that we have seen ask their student for a project in class or for the start of their research to participate to the shared task. So what we are facing with is a bunch of students for whom this is the first time that they are actually running a shared task and writing a paper. And what we are facing is that the people are running the shared task, and then after they disappear because they are afraid to write the paper. So the point here is we were starting the discussion actually in SIMEVAL, so it's a long question. You have a nice thread on BioNLP about that question. So what I'm thinking here is to use pre-draft or patterns to help the student to fill that, so that at least they are not left on their own writing a research paper that they have no idea of what to do, how to do that, like us basically. So writing a poster that they can fill, writing already made document that they can extend. So that will be this kind of discussions. How can we help student writing the document that we want so that we can actually publish that later on, and that we are sure that we have documentation of the system at the end of the shared task. So that's the goal.
So there are no further questions. I think we can declare the session concluded.
Thank you.
We can give a break now. I think we can start in about 20 minutes. One of the presentations in the next session.
Yes, so maybe we can begin the second session at 11:40. 11:40 because yeah, we miss one speaker in the second session. So the original schedule is the second session begins at 11:30, but I think we can begin at 11:40. Okay.
これスライドショーにすると、あ、いけたいけた。
だからいいんだよね。
ああ、よかった。
そう切っちゃうとね、こっちで操作ができなくなる。
これ英語じゃないけど大丈夫ですか？
いいんじゃない？いいんじゃない？
言語英語ってすぐ変
いや、
えられない。
いいよ、もう大丈夫大丈夫。わかるでしょう。日本語でもここぐらい。
HDMI ダメだったから使わなかったのかな。
ね。
これがコード類がぐちゃぐちゃだ。
間に合いました。
ありがとうございます。お疲れ様です。
ダウンロードしてきましたね。
ありがとうございます。
そして日本語の PC だけど大丈夫かなっていう。まあ大丈夫だ。
カタカナで書いてある。
スライド。
見てみて。
わかると思う。そうですね。そのぐらいは。
Is there a microphone? Is there a microphone?
Welcome back. If we all take our seats, we'll have our next speaker. Our next speaker is Togotv. We're very happy to have her with us to give a keynote today. Dr. Tao is perfect to be here. She's a biologist, a computer scientist, and an ontologist who works in clinical NLP now. And instead of telling you all about her, I will recommend her paper on Reddit and human papillomavirus, going back to Graciela's point about the importance of reproducible research. It is replicable. Not only does the paper give all parameters, but even the version numbers of the library. Almost no one does that. You can evaluate reproducibility because the paper includes many values and the relationships between them. And finally, addressing again Graciela's point about the lack of value of just writing another paper about an NLP component. It's a paper that finishes with the actual implications of the findings for public health. So with that, I present you Dr. Togotv.
Thanks, Kevin, for the nice introduction. I need this. Okay. Oh, I have one here, actually. Okay. Thanks, Kevin, for the nice introduction. Good morning, everyone. I'm very excited to be here today. Actually, this is my first time attending BLA. I don't know why I didn't find it earlier, but this is very relevant to what I'm doing here. Thanks to the organizer for inviting me. So today I'm going to talk about my recent research activities on using big biomedical data for different kind of analysis. As Kevin said, I was trained as a biologist and a computer scientist. So my main task now is to develop advanced technologies to solve real biomedical problems. And the major technology I'm using is ontology and semantic technologies. A little bit of introduction. Oh, I'm not a Windows user. Let me see what. Okay, here we go. So a little bit of background information. As we all know, we're now in the big data era, and the average person today processes more data in a single day than a person a few hundred years ago in their entire lifetime. So big data can bring big potentials. So far, there's a recent publication indicate that 80% of the current data are not being directly usable by computer programs because of the way they store the data, the format of data, and etc. So the estimated value is about $400 billion if we can fully leverage this data. 5 exabytes of data, that sounds a lot, big amount of data. These actually all the data generated before year 2003. But actually, in year 2011, it only took us 2 days to generate the same amount of data. And 2 years later, 10 minutes. The latest number I got is for year 2016, only took us 1 minute to generate the same amount of data. So we can imagine this 2020 now, it probably only take us seconds to generate this vast amount of data. I do have a projection for healthcare data. So this year, we already have more than 2,000 exabytes of healthcare data. So this gave us big opportunities. Of course, there's also big challenges involved of biomedical data analysis. First of all, a lot of data are designed for different purposes. They were, for example, EHR data, they were designed for, for the physicians, doctors, and nurses to keep a record of what happened to the patients. They're not designed for research purposes. Not to mention, these data can come from everywhere, right? I list a few. There could be like clinical data, public health data, billing data for insurance companies, administrative data, publication, and etc. So these data are, heterogeneous. There could be a lot of missing data, incomplete data. So how do we deal with them, right? Of course, in order to combine the data, make powerful and more comprehensive analysis of the data, or make it more meaningful, it requires expertise from different domains. Biomedical informatics is a domain of highly interdisciplinary area. So, usually we will need to work with people from biology, medicine, computer science, people working together to make the data more sensible. So what I'm trying to do is to create an ecosystem for data-centered informatics research. So here is that data saves lives. So our dean of the School of Biomedical Informatics always says, a doctor can only save one life at a time, but as a data scientist, we can save millions of lives at the same time because, this is power of the data, basically. So here is, basically what I am here. So basically, I'm a biomedical informatics researcher, and we're trying to develop core technologies here, around by AI. I'm also doing NLP ontology stuff. And the one important component is, we need to work with domain experts. For example, for annotating data in a specific domain, we have to work closely with domain experts in order to understand their specific real-world questions, and in order to understand their data better, in order to provide more meaningful solutions. And for my own research, there are actually 3 major steps. One is data extraction. So basically, as we said, we all know data are from everywhere and in different formats. So we need to develop text mining and NLP technologies to extract them. And after that, we need to integrate the data, through what I'm doing is through ontology and semantic web technologies to standardize the data, normalize the data, so that we can put data from different sources together. And the third step, of course, is data analysis. So we do that usually through machine learning and statistical methods. So I put some slide about ontology and the semantic web just for background. But I guess for this audience, most of us know what ontologies are, right? So I will just go through the slides briefly. So a little bit history about the semantic web. The idea of semantic web was first, I think it was relatively new. The first visionary paper was published about 20 years ago in issue of Scientific American. So the lead author is certain Tim Berners-Lee. He also is a co-inventor of the World Wide Web we're currently using. But their original vision about the web, it was actually much more ambitious than what we're having now. So basically, the basic idea is, it needs to be more machine readable and machine understandable, so that computer agents can do a lot of more stuff for us automatically. I think, after 20 years, we are actually, getting there. But if you are interested, you can read their original paper. They actually had quite a few interesting examples in healthcare domain about how AI and semantic technologies can help patients and doctors to make their lives easier. So one problem with the current indexing system, with current internet, is a lot of documents or a lot of information is still organized by documents. So if we, go to a search engine, put a keyword, the search engine sometimes would, just give us a lot of information, right? Return us a lot of links, and we'll still have to go through the document one by one, open the document in order to find the information we're looking for. This kind of keyword-based search is usually very ambiguous. For example, here I'm searching for gene CDK4, but this web page is actually about a book. Also, the acronym is CDK4, which is not relevant to the gene at all. So even if we find the web page that contains of the question I'm asking for, contains the information I'm looking for, I'll still have to go through the page in order to find the information I'm looking for. So this process is sometimes very time-consuming and tedious. And what is the problem? Consider a typical web page like this. So this is in HTML, which is a markup language. So the computer program knows, usually, HTML will give us a render information, for example, the color, the size of the font and things like that, and also the hyperlinks. But the semantic content is actually only accessible for us, not to computer programs. So what information can we see? Even without the render information, right? We can still figure out what it's about. It's a conference, and because we can understand English. But without, semantics, this is what a computer can see. It's just a bunch of symbols because, there's no semantics. The keyword-based search is sometimes we can view it as just some kind of string match, right? So what can we do? We need to add semantics. We need to make sure computer programs understand, what the web page or any document talks about. So we do it through, semantic annotation using domain ontologies. So ontology can do a lot of wonderful things. Since, I think this audience already familiar with what ontologies are, we'll skip the introduction. So basically, the basic idea is, we can view the ontology as the brain of a computer agent. It can provide, knowledge base. It can do a lot of things. For example, in the biomedical domain, there exists a lot of ontology variously. NCBio, I think, currently has like more than 600 biomedical ontologies, and people design ontology for different purposes. For example, you can use ontology as standard to normalize data. You can use ontologies for providing domain knowledge. You can use ontology for help facilitate NLP and data exchange, or for reasoning. Depends on the specific use cases. We can design ontologies accordingly. So enough background. I want to introduce a few use cases. How we actually use ontologies to solve different biomedical problems. The first project is called Timer. So this is actually relevant to the timeline problem Rashila was talking about. Maybe this can help her to solve that problem. But our focus was using EHR data, and we want to see if we can create a timeline of what happened to a particular patient or a group of patients, so that we can study their medical history. This is also supported by NLM, National Library of Medicine of US NIH. And the project is called TAMR, which stands for Temporal Information Modeling, Extraction, and Reasoning. So as we all know, the temporal dimension is very important in clinical research. EHR by itself is historical, and if we can successfully uncover temporal patterns in EHR data or any kind of clinical reports, it can help us to do a lot of different things. For example, we can understand better disease progression. We can help clinicians to predict different risk factors for a group of patients or a particular patient, for personalized medicine, etc. Of course, we are also facing a lot of challenges. Again, there are a lot of data. And for temporal data in particular, a lot of temporal information is actually embedded in clinical narratives, in clinical text. Not to mention that many temporal relations are not explicitly stated in the original document, but rather inferred. I'll give you guys a very simple example. So basically, these are three sentences, from two different nodes. And we have one simple question. Basically, did the patient experience some symptom before, some, they using the drug, right? And so basically, the first step is, of course, to recognize the clinical events. It's an NER problem, name entity recognition in NLP, and already assume that it's solved. So I marked 4 different events here, and first we need to be able to infer that event 1 is the same event of event 3. So this is sort of a co-reference problem. And then here, from the second sentence, we know that event 2 was before event 3. So this is sort of like a temporal relation extraction. Then, because of these 2 facts, we can infer this one. And then there are 2 days here. We also need to be able to link the days to the particular event, and based on the days, we can calculate that event 1 was before event 4, and then since we have these 2 facts, combine them together, we can we know that event 2 was before event 4, which eventually answered our questions. So as we can see, so this is a very simple question. Even if we want to do it manually, it took us several steps to be able to understand the question and answer the question. So if we want to do it automatically, it's actually a challenging problem, and which involve different part of technologies, NLP and semantic reasoning. And here is another example. So basically, if we want to study patients' medical history, we have access to both their clinical notes and data from structured database. In this example, from the unstructured text, we know that patient has a fasting glucose test, and we know the result. And then 2 days after the test, something happened to the patient, but we don't know when the test was. We don't know when the symptom happened, but we know the node date, and we can actually go to the structured data, and that's a linked code for fasting glucose test, and the values are the same, and the date is within within the range of the node date. So we can safely infer that these 2 right things are the same event, And based on that, we can put it on timeline, and we can calculate what 2 days later is, and put the second event on the timeline. So sometimes if we want to, we consider different data sources together, we can actually, they can actually help us to infer more temporal relations. So what we are trying to develop is basically a ontology-centered framework. We have an ontology called Central Clinical Narrative Temporal Relation Ontology. Basically, this ontology can serve 3 different purposes. The first one is for semantic representation. So we developed the ontology to formally represent the temporal domain, temporal relations, temporal expressions, and etc. And the second purpose of the ontology is to connect the ontology with NLP. So the ontology sort of serves as the annotation guideline for our NLP framework. And the third purpose for the ontology is knowledge base. So basically, around in the ontology, we specify different rules for temporal reasoning. We also build a timer API so that some of the reasoning can be done through our code. So this is a very high-level overview of the ontology itself. So as we can know, we define time instant, time interval. We also define different kinds of relations. So we published actually 2 papers for Central, but now we have a newer version. It's called TEO, time event ontology, because we saw the time domain is actually not just for clinical problems. So we want to make it more general. So we're now working on a newer version of the ontology called time event ontology. I think all the ontology are published. So if you are interested, I think it's on NDBO Bioportal. So the second step is, see if we can actually actually annotate information with respect to the ontology. We actually, we did a quick search online, but we couldn't find any tools that can link ontologies. So basically, use ontology as an annotation guideline. So we started to develop our own, which is called Semantator. So, I think you're all familiar with Protege. This is a Protege plugin. So basically, the idea is to be able to build the text to be annotated, the ontology itself, and the annotated result in the same environment. And we can see here, the instances belong to different to the same class will appear in the same color, and we can actually also link the relationship here using Protege. So Semantator is designed as a GUI for users to browse, query, and edit, annotate results in the original context. So we try to provide 2 different modes. One is manual annotation, basically for us to develop training corpus for NLP. And there are also semi-automatic annotation mode. We try to link with kind of state-of-art NLP tools, such as CLAMP and the CTake, so that some of the name entities can be pre-annotated. And of course, since it's linked to ontology, we're trying to do consistent checking and some kind of semantic reasoning. The tool can be downloaded through this URI. So basically, we have 3 parts, right? So first is representation, that's the ontology itself. Second is annotation, and third is reasoning. So we do semantic reasoning through different ways. One is through description logic, and this rule-based logic, and also we also add on a Java-based API so that some of the very comprehensive reasoning can be done through our Java code. So here are some of the main functions we developed. The first one is, of course, find a return list of events that match searching criteria. So that's a simple function. And also, we can answer the when question. So if we want to know when was the patient diagnosed with diabetes, given the event, we can return the time if it's available. Also, we can answer the how long question. So that is a duration of a specific event or the duration between two given events. And these are more like the Boolean questions. Say, can we tell you the if given two events, if we can return the temporal relations between the two events, say was event 1 before event 2, or the other way. Or given one event and the time point, we can return if that event was before or after that time point. And the last function is sort of a very comprehensive function. So basically, you gave a set of events, can we sort the event on the timeline? So sort of to be able to view the patient medical history, as an example. So this is from the technology point of view. We're actually applying the timer system into different real-world problems. One is medical device safety analysis. So we got the report from FDA system called MODI, which is a public available database released by the US FDA. And it's actually about adverse events for medical devices. And we actually focused on specific medical devices standard implementation. And we published a paper just to verify that the system works. And the second use case is about vaccine safety analysis. We studied flu shot, and we studied measles vaccines, and see if we can extract events, adverse events and their temporal relations from the reports, and if we can use data to predict severe events before they happen, so that we can do early intervention. And also, most recently, we also try to use a timbre application for disease risk prediction. So we focus on asthma and also HIV infection risk. So basically, the timbre application the timbre framework can provide the data for us, clean up the data or pre-process data, and then we can develop either statistic and machine learning methods to do this kind of either safety analysis or prediction algorithms. So since for the because we have time limitations, so I don't have time to discuss them in details, but all these 3 projects, we have published papers. So we can talk offline if you're interested in these applications. So let's shift the gear a little bit. So for timer, we use ontology sort of for reasoning and for representation. But I also want to talk about a use case where we use ontology to support patient communication and education, because we all know ontology can also serve as describing or defining a domain knowledge for a specific domain. So what we're trying to do is we try to create an ontology that sort of serve as a knowledge base for consumers. And we focus on vaccine communication because this is a very important topic. And a lot of studies indicate that providers, they don't really have enough time to communicate with their patients even during clinical visit for these kind of topics. So, if we have our phone, we can ask Siri about the weather or about our schedule. But what about if we can ask her about health-related questions, right? So we would like to provide some kind of mHealth solution for that. Actually, both Apple Siri and Amazon Alexa, they use ontologies as their backend knowledge base. So that's how we started this project, and we tried to develop an ontology in the vaccine domain, focus on consumer education that could allow patients to ask specific questions regarding to vaccine, and also to facilitate dialogue, consulting dialogue. So we started to build this ontology called vaccine information statement ontology. And so again, this is the knowledge base to, so that we can create that vaccine theory. So the initial version took actually a lot of annotation, manual annotation, and we include 6 baby vaccines and the HPV vaccine. So basically, we designed the meta ontology, sort of work with domain experts, clinicians, pediatric nurses, and to figure out what are the most important topics that would persuade people that would promote vaccination. And then based on that, we build a meta-level ontology, and then we start to build the instance level by extract information from reliable sources, for example, from CDC, and also from educational materials developed by different hospitals. And then since we also focus on HPV vaccine, HPV is actually a virus that related to different type of cancers. So we thought we would also create a cancer ontology that can provide basic knowledge about cancer information to the users. Most of existing ontologies is, there are a lot of ontologies actually about cancer, but most of them are just, for professionals, from about the, treatment of cancer, or, the biological mechanism of cancer, but the consumers really don't care about that. They care about what happened if they have cancer, what are the treatment options, adverse events, and things like that. So we build the cancer ontology around that perspectives. And when we first built the vaccine ontology, most of the work were done manually, but we realized that it wouldn't be scalable. So we started to develop this information extraction tool, so to help this process to be semi-automatic. And basically, this tool can extract knowledge triples from text, and our manual annotator will, of course, still double check the accuracy of the extraction. But most of the triples are correct. So we have published a paper about a couple of years ago to report this information extraction effort. And of course, if we are talking about vaccine, there are a lot of misinformation about the vaccine. And during our pilot study, we actually implement the tool, and then we provide the tool to different users, parents, or college students, and they ask a lot of questions from the misinformation perspective. For example, if can vaccine cause autism, things like that. So we realized that misinformation is also very important to be covered for this kind of patient communication. So we also start to implement a ontology called the misinformation ontology. So so here is actually the the interface. So currently we don't have a face of the agent, but we can sort of based on the conversation, the dialogue from the with the users, we can somehow infer their emotion, and we display like an emoticon on the interface when when talking to the user, so that sort of to attract their attentions. And we have tested these two, I think, with about 30 also parents and also a few hundreds of college students. And the usability test shows that they all like the tool, but of course we need to put more knowledge, enrich the ontology in the future to make sure that we cover all sort of questions from the users. All right, so I think I still have around 10 minutes or so. So since the theme of the plastics is about social media, so I want to talk a little bit about what we have done with social media data. So basically, we focus on using Twitter data for public health analysis. So as we all know, like a lot of people are using social media right now, especially the young generation. They actually trust, what their friends say on their social network about medical information. So what we are trying to do is to develop a machine learning based approach to extract popular opinions on different health relevant topics using Twitter data. And of course, we're dealing with social media data. There are a lot of different data. So we feel like AI is very necessary. So basically, we want to, use AI to solve social, automatically extract information from social media data. So this is, I use Twitter as an example. I also use Reddit in some other projects. So again, this project focuses on vaccine. We know vaccine have saved a lot of lives, but at least in the US, the vaccine coverage is not optimal, especially for certain type of vaccines. For example, HPV vaccine is relatively new, and a lot of parents don't know about it, or have doubt about it. Some people think it's only for girls, but actually for both girls and boys. And some people think, it's not necessary to have HPV vaccine. So basically, we want to understand better why people are refusing it, why people are delaying it, to be able to provide tailored intervention. And a lot of public health researchers using a traditional surveying method to do that, but again, it cannot be scalable, and sometimes, it's not real time, right? So what we are trying to do is to use Twitter to automatically extract information, like understand what they're saying, they're talking about HPV, for example, HPV vaccine, and then see if we can make sense out of it, and see if we can find their particular barriers, so that we can do something about it. So here is the overall project design. So basically, we focus on two steps. So of course, we collect the data from Twitter, and then we do some pre-processing, because Twitter text is very different than regular text. And the tool focus will be, first, we want to understand what they are saying about a specific health topic. For example, HPV vaccine, or recently we start studying like PrEP, or opioid, or like e-cigarette use, things like that. And we actually try to align the social media content to public health theories, for example, the behavior change models and health belief models, so that we can understand better the rationale behind their behavior. And another important step is to be able to understand who they are, right? So the user profiles. So many people don't actually provide their real demographic information on social media, but we can actually try to infer who they are based on what they said. So we're developing algorithm to see their, to detect their gender, their age groups, their location, their what else, their races, and etc. Like sexual orientation, because like for example, for the PrEP relevant topic, it's very important to know their sexual orientation. So these are the major two steps, and after both of them are based deep learning based approaches, and then we can do different stuff. For example, we can provide real-time surveillance to see, like for example for HPV, we can see California is like very light, and Texas is like very conservative. And also, based on what they said, we can also provide personalized intervention. Say someone said, oh, I know HPV vaccine is useful, but I cannot afford it. Then we can, actually tell that person that, your insurance will probably cover it. And if someone said, oh, measles vaccine causes autism, then we can actually text that person saying, this is not true. So this kind of tailored intervention usually is more effective than, just public or general message, basically. And also, because we know who they are, we can also design the message according to their age and their gender and their, social status. So to make it more attractive, or they can pay more attention about, what the intervention message, basically. So, of course, there are a lot of more we're doing, but we're running out of time. So I would like to thank my group members, Ontology Research Group at UT Health, and also my wonderful collaborators. I also would like to acknowledge the funding resources that support my research. All right, I think we have 5 minutes for questions. Thanks, everyone.
So that the patient summarizer thing you talked about, does that only work with narratives, or does it look at the whole structured and unstructured data from patients?
Well, yeah, I look at both structured and unstructured data. But of course, when we develop the tool, we're develop it piece by piece, right? So the NLP part is actually just for the text information. But if we add the structured data, we can actually infer more information.
So how often do you find discrepancies between what you find with the NLP versus what's actually coded?
Well, actually, that's a good question. We can actually, sometimes it's hard to link them together, basically, because, is that what you were asking for?
Yeah.
Yeah, so sometimes it's hard to link them together, but only if we find a very strong signal, we try to link them together, as the example I showed you guys.
Okay, and then one last, does it run just your local data, patient record system, or does it run like a OMOP or a common data model?
Yeah, that's a good question. Well, we haven't linked that to OMOP yet. So currently we're testing the two data sets. One is from our local UC physician data warehouse, and another one is through our collaborator from Mayo Clinic.
Okay, on really great work. Thank you for presenting.
Thank you.
On the social media aspect, have you looked at the potential problem there is with inference from data in social media? The terms of use of Twitter prohibit us from making inferences, and it's specifically like that. So it's written like that, meaning particularly for things like socioeconomic status, sexual preference, and so on. There is a difference between inferring and extracting.
Right.
So the way we have addressed it is by using what we call the self-declarations. So I am not inferring somebody is pregnant. I am extracting their self-declaration of pregnancy. So the engines that we do are NLP engines that basically find these things. So language is not used, for example, to determine gender, or shouldn't be used. mind you. There's some systems, obviously, that have tried. If we are true to that, then the systems we design are sort of limited to some of the stuff that we can do.
Right.
So I don't know what your thoughts are on that one.
Well, I think that's the limitation of the dataset itself. I don't think we can do anything. But one way we're trying to do that is, we try to, link that through, Amazon MTurks. Basically, if we want to actually provide intervention to that particular user, for example, we would have different options. Basically, first one, we could, send them message and, ask them for consent, and then they can, do a survey or something, but we can find out information, right? And the other one is through MTurk, we can actually recruit people there, and if they give us consent and, let us know about their social status, then we can go from there, I guess.
We still have some time for questions.
I think there's a question here. I think it's off.
Now it's on.
Yes.
So this problem of extracting temporal relationships from text, specifically medical records, is something that is of great interest to us as well in Copenhagen. But one of the problems you always have with electronic health records is, of course, that of language. That in different countries you always write in the local language.
Right.
How difficult would it be to adapt the timer to
So,
work on non-English languages?
Oh, wow. That's a good question. Actually, I think it's very challenging if it's not actually within English. Actually, different physicians have different, ways to write things basically. And one way is say, the tool could be general, but we need a new training set basically, right? If you have your annotation, then we can try to retrain the program and see if it works accordingly.
And how big a training set would you need?
Well, the bigger the better.
Well, that's always the case.
Right. It depends. How specific you want to define the temporal relations. For example, I assume for temporal expression it's relatively easier because we can use regular expression and time is like general to everybody, right? But for temporal relations, in the ontology we actually have different level of granularities basically, right? You can just say I want to focus on just before and after and some kind of equal. Maybe that could be done relatively easy. But if you want to focus on more specific temporal relations, for example, the ontology actually has more than, I think, 20 or 30 temporal relations. We have like before, start before star, start before after, things like that. If we want to focus on that level of detail, then of course, it needs a big corpus basically.
Yeah, what we would really like to do is to be able to assign timestamps, right? We have a node, we know when that node is from, but the node says that something happened 2 weeks ago.
I see.
Then you basically have to do math on top of it.
I see. I mean, timestamp itself, I guess, it's relatively easy, I would say relatively, than temporal relations. But sometimes, you cannot treat them separately because, you will, if you just say, I only focus on timestamps without relation, you would lose a lot of information basically. But if you just say this thing happened on February 2nd and 2 weeks later something happened, then I guess you can adapt the two, I guess. Yeah.
As a linguist, I will posit that in principle it's no harder to adapt it to a new language than to a new physician. Feel free to falsify.
Yeah.
We have time for 1 or 2 more questions.
On your temporal questions and reasoning, actually my question is on reasoning. Are you adding, do you have currently advances on that area? So for example, in the example you presented, it's sort of straightforward, the event 1 before event 2 and event 3 and then event 2, so on. So that's straightforward inference. But for example, the question you put was, did the patient had chills before the dose of whatever medication you had? what if you have something like could the chills be a side effect of that medication? See what I mean?
Yes.
There's like two levels of reasoning there where you have to have knowledge, general knowledge, like ADRs are after
I
the
mean,
medication.
It depends, I guess. You know, I don't think we can do causal relationship because we cannot just simply assume that, right? You should say something called.
That's why the question is could. It's like, could it be? So, for example, the fact that they were before the medication rules out totally the possibility. Whereas if it's after the medication, then it is possible.
I see what you're saying. So,
see what I mean?
Yeah. So, I mean, we can add that to the ontology. It depends on the specific use case, right? But the ontology itself is just about temporal reasoning, basically.
So as a question for everyone who does social media data, if we have time for a discussion, if you could all talk about the issues of working with observational data and whether or not we can draw any causal conclusions from this kind of work. So let's thank our speaker.
Thanks, everyone.
Our next speaker is Nuria Kerad-Rosinak. She'll be talking about a data set.
Presentation プレゼンテーションはどこだ
PDF の
あ、プレゼンテーション
真ん中の方にない
でもですね
デスクトップの真ん中に
プレゼンテーション
OK?
あ、でもこれプレゼンテーションするためには何をしたらいいですかプレゼンテーションしたい
ああ、どうするんだろう
PDF ですよね PDF so choose it スクリーン
じゃないいやフルスクリーンだと思うその下これじゃないかなこれちゃううん、違う
Yes. Is it showing or not? Screen は
どうした
スクリーン見えない映してない映してない
本当映ってないなんで
I'm very excited to be here. Hello, I'm very excited to be here. It's my first blog. It's starting exciting.
What? ここでやるよ。Okay.
Okay, so I'm gonna present a proposal that started in a prior Hackathon working with Dong, and the project is in the context of the work I did in my last position in my postdoc at Scripps Research in California. And it was it started in the context of supporting and working in collaboration with domain experts in the context of hypothesis generation on a specific rare disease called NGLE1 deficiency. And it's not very focused on social media mining, so I did my best to try to connect the proposal to the focus of the blog. So NGLE1 deficiency, it's a genetic metabolic disorder that it's diagnosed to less than 100 patients currently, and there is no treatment right now. So it's a rare disease. It has several definitions. Rare diseases in the U.S. A rare disease is a disease that it affects 1 person per 200,000 persons. And as you can see, our use case is an ultra rare disease. Rare diseases are mostly undiagnosed, and they mostly don't have treatment because are so rare that there is a lack of knowledge and data. Also, they are based on small communities. That means that they have not a lot of resources, but they are very active on social media. So to try to engage and find new possible potential patients with this rare disease. So in fact, I found there is starting also to be in the scientific publications work on mining social media or oriented in research on rare diseases. So maybe there is potential here. Also, we don't know the causes of these rare diseases, but the majority that we know are genetic and have inherited patterns. So to try to gain new knowledge, to increase the understanding of the pathology of these rare diseases, hypothesis generation basically is around trying to find links between a gene. In our case, it's an enzyme, a gene that encodes an enzyme that is called NGLE1 to phenotypes. So, and our goal was to support these domain experts, biologists, to find explanations based on evidence. So the first question was how to mine relevant knowledge for this use case. So where is the knowledge? Where should we search this knowledge? So as we all know, this knowledge is mainly in the literature, it's in free text. Also we have a lot of knowledge is already structured in databases, and importantly, a lot of knowledge is in domain experts, researchers, and patients. So the first thing on how to mine it to generate this new hypothesis is accessing this knowledge. So the primary source to access this knowledge, it's reviews. Are reviews. But reviews mainly are, we found reviews as free text. So that hinders the mining, the computational mining of these great resources, the reviews. So this is the problem that we faced. And why is it significant? Rare diseases affect, one rare disease affect few people, but globally, because there are right now recognized like 7,000 rare diseases globally, is a real societal burden, because it's estimated that affects in the US 30 million people. So, and only the 5% of these diseases have a FDA treatment. So the value of this work is try to make, our goal was try to make reviews a valuable resource for hypothesis generation to get understanding, to speed up the development of new treatments for these rare diseases, and also the knowledge get from rare diseases can be transferred to common diseases. So technologically, our goal was to make a review turned into a computational resource that is human but also computer accessible, that is actionable, knowledge resource for hypothesis generation in the case of the rare disease case, that integrates different facts that we need to mine and try to find out new links, new explanations, that allows collaborative science, and that allows this community input and contribution to this resource to make hypothesis generation more efficient. So an existing solution are the use of these knowledge graphs that are very useful to integrate, represent, and mine knowledge for discovery. But in the case of use them to review knowledge around a disease, a rare disease, the existing informatic resources have several limitations. The most important is that they have different goals, are built for a different goal, like domain-centric review articles. They are not domain-specific, usually, oh my God. And they focus on few type of edges in the graph. So our solution was to develop these disease-centric knowledge graphs. We developed this Angle1 deficiency knowledge graph, where the most important contribution was the curation part, but we also review information relevant from different databases. It was centric to the disease and the specific question, hypothesis of the researchers. We structured like a knowledge graph, or as we call structured reviews, and we make an application to navigate and contribute by the community to build this, curate this graph. Is based this creation tool on Wikibase that it allows to make fair source, the graph fair at source, and it's community driven. So, and can be generalized to other rare diseases. So, but the limitation of our approach is that we are not using the major component of knowledge, that is the literature. So we need to annotate text from the literature in a user disease and research question-centric way. So our proposal is to mine PubMed and maybe discuss if it's reasonable to mine social media for that. Text mining meeting user needs and in order to add curation for graph building. So the proposal is to use pub annotation, that the pub annotation ecosystem uses agile text mining approach that is useful and proper to build customized annotation data sets. And it can be used to guide curation for disease graph building. Also to use Wikibase that helps to build living knowledge graphs because they allow to add new manual annotations above other things. And the goal of our proposal is to build this pub annotation Angle1 deficiency-oriented data set with different steps and with two possible connections to the project using Wikibase as an evaluation tool of the annotation data set, or using pub annotation to guide to build this graph by curation in an efficient way. Importantly, very thank you to the organizers for allowing me to be here, and very excited, and thank you.
We have time for a question or two while our next speaker comes up.
Okay. For your social media, it's usually, I mean, it doesn't need to be forced. There is a lot of stuff out there. So anyway, it is a very, very rich source, and it'll be really neat to talk about it later. So basically how to get this community and data on how people express what they think about it, how they are affected, and all that. I think that's a really cool application.
Nice, because in the beginning I thought, oh yeah, it seems it seems a nice source, but when I listen to your talks, maybe it doesn't make sense, maybe it's not. Then
yeah, no, it is. It's like, so we can talk more about it.
Perfect, thank you.
Let's take our speaker again. Our next speaker is Gianna Souza.
Hi, good morning or good afternoon. I'm going to present the work that we have developed for a human phenotype gene relations dataset, and also the challenges that we aim to tackle now in this block. So the motivation is about the same as the previous speaker. So we want to know which phenotypes are associated with certain genes, and we need to go through biomedical literature to have that information. The problem with that is that we have a lot of literature, and if you are interested in more than one pair or one relation, you have to go through many articles to derive meaningful information. So, and most of this information is unstructural and heterogeneous, and takes a lot of time. So the problem with relation extraction is that the biomedical relation extraction systems are scarce and limited, mostly because they are made for specific relations and do not generalize well. And the problem here is there a lack of annotated data sets, both in English and other languages. So what we did already was a silver standard corpus where we used tools that we previously developed to annotate genes and phenotypes. We use a gold standard knowledge base provided by the Human Phenotype Ontology that has the genes and the relation and their relations to phenotypes. And from that, this is a simple distance supervision technique, and we were not expecting, but we got quite good results, and mostly because we only mine abstracts, and in abstracts it's more, most of the sentences that contain relations are affirmative, and so it's normal to have good results. But we, since then, identified several problems, and we want to expand this data set. The first problem is even if a gene is related to a phenotype in the knowledge base, we have examples where the relation is not in the sentence. So here we have to distinguish between true and false relations. And then after we do these distinctions, if we have a true relation, we have to distinguish between positive and negative relations, which is also another problem. And finally, if we are able to do that, we have known relations that are in the knowledge base, and we have unknown relations that test as false positives that are not in the knowledge base, but they could be. So this is the pipeline. We want to be able to use our data set and go through these 3 stages in order to have a true data set and a well-annotated data set. So we propose using semantic similarity measures to check if a known relation has the potential to be a known relation. And other improvements that could be done were grasp multiple word entities. We had the problem with that in the phenotypes. And also our data set was partially curated by biochemistry, and it curated of our total almost 8,000 relations. It curated 2,389 relations. In these relations, he found out other problems and ambiguities. Some problems are easy to fix, and others are not. And mostly the problems are related to name entity recognition of genes. And what happens frequently is that a gene is confused for another thing, like a medical term or a molecular compound. And this happens because proteins and genes, for instance, share the same names. And even if you have, that we had manually verified our annotations, we don't have the expertise, enough expertise to know if it is a protein or if it is a gene, for instance. So we like to make this distinguish between all these ambiguities, if possible. That's a thing that we want to explore, and we have this partially data set to evaluate our progress. So that's it.
Thank you for talking about problems. It's much more interesting than talking about all of our successes. We have time for some questions. Could you talk about how you found the problems?
These are, we already knew that we had this problem because our approach was very simplistic and with distant supervision. And we were able to catch examples of these, especially the red ones.
Is that a manual review process primarily, and who did the review? What can you tell us about how to find problems in our own data?
In our first data set, we asked, we manually reviewed a short amount of relations. Not we, but people in our group that had bachelors in biology and biochemistry, and we defined this as experts. But since then, we have a second version of the data set. In this version, we had proper biochemistry that was fully aware of the differences between all these things, and he manually verified all the sentences. And for instance, we have several problems. And the main problems was the one that I talked about, that I don't if it is important to distinguish when we have a relation between a phenotype and a gene, or the phenotype and the protein that's a result of this gene. This is a thing that needs to be discussed. It's because with our first data set, we have already people that used it and cited it, and they had good results, but they are doing it ignorantly, essentially, as most of we that are not from the bio background are doing it. So we overestimate the quality of our models and of our data sets because we don't know these differences. I didn't know all of these problems. So I think it's very important to define what is actually correct, and if it is important for the end result.
You have time for another question.
So there are a number of as far as I know, there are a number of data sets which have relation or notation between human phenotypes and genes. So have you had a chance to compare your data with those data sets?
There's actually not a lot of data sets with human phenotypes specifically. There are some with phenotypes in general, and also with plant phenotypes. As far as I know, our first paper was the first that focused on human phenotypes and genes. It will be interesting to compare with the normal phenotype gene. That's another problem. You can find articles that have relations that says gene phenotype, but what they mean by phenotype is diseases, and what they mean by they link to the disease ontology, and it's not a phenotype. So that's another problem. Yeah, I don't think there are data sets focused on this, at least at the time that we made ours.
In a second, let's thank our speaker. Jin Dong, do you want to say anything about lunch?
Yes, you can leave your belongings in this room. This room will be secured, so it's completely fine. You can leave your bags. Yes, and in the back side of your name tag, there is a QR code which will give you lunch map around here.
So let's thank our speaker again, and we'll be back at 2:30.
You can. So.
Welcome back from lunch. Our next speaker is Fabio Rino.
Okay, thank you. So I am, or I was until recently, a group leader at the University of Zurich. And what I want to present you today is some activities in my group which focus on biomedical text mining. I said I was because I'm moving to another institute in Switzerland, and I'm not completely sure how much of this activity I will be able to bring to my new institute. Okay, so these are the projects in which my group in Zurich has been involved recently, dealing with text in different formats, the scientific literature, clinical records, social media, veterinary reports, also helping doing assisted curation, and providing some basic tools. I would love to give you a presentation about each of these projects, but obviously I don't have the time, so I would focus only on two of them. I give a quick overview first, and then I focus on two of them. MedMon, which is about social media mining, and a recent participation in Share Task, and well, I'll use it to present some of the tools that we provide. So, quick overview, SciMine is about finding in the scientific literature causes of psychological disorders. There are many causes of psychological disorders. There can various different types of entities, and the goal was to get from the literature the possible causes of a set of disorders, predefined set of disorders. So we started by creating a corpus, and the idea is that, for example, a disorder like panic attacks, depression, we want to find associated causes. In melanobase, another relatively large project, the idea is starting from a disease, for example, melanoma, looking into literature for possible causes of the disease, genetic causes, say, for example, genes, and treatments or other related factors associated with the disease. So the idea is to mine the literature, find association between a disease, here represented by its mesh term, and say in this case a gene. The idea is to use some distance supervision, so get from a database, for example, associations of genes and the disease, find those mentions in the literature, and use it to interactively construct a database. Another project was a collaboration with Roche, in which the goal was to disambiguate author names. In the case we have two Holmes, are these the same Holmes or not? Seems trivial, but in reality this is not so obvious, because in many cases some information is not provided. For example, the affiliation might not be there, or the author can change affiliation, so you're no longer sure whether it's the same author or not. We have several publications about this work. Another project, we deal with clinical text, clinical reports for a specific case, all the patients with which will take antithrombotic drugs. And the idea is to analyze these electronic records and find information that can help monitor their diseases. MedMon is the one about social media mining. It's a collaboration with Roche again. And the idea is that we want to find information in social media about the patient. I will say a few words more about this in a moment. Another project is a collaboration with the veterinary faculty of the University of Zurich and Bern. And the idea is that veterinary doctors write reports about the animals that they inspect. And these reports contain a lot of domain-specific terminology. In this case, it's in German, because these reports are written in German, like clinical records. Obviously, they are written in the local language. And we try to map the terminology we find in the reports to a reference ontology, in this case, the UMLS. And this allows us to connect information with the reports to the records, and also detect cases in which the same disease is expressed in different ways. And this allows then our partners to do epidemiological studies, distributions of the reports by type of animals, by locations, and for example, a disease spreading in a specific location, or temporal studies of these reports. Another project in which I am a partner is actually was led by a group in Mexico. That's my connection with Mexico. The Regulon DB in Cuernavaca, Mexico, which is one of the major databases, life sciences database. It provides information about E. coli. And the goal there is to help the curators to find the information in the papers that they need to curate the literature. We provided a tool called Odin, which allows them to visualize in a paper entities that are potentially relevant for their for their curation tasks, and then extract them. As an example, in a test application, we got from their database the list of genes and transcription factors that they are interested in. In this case, MTR transcription factor, MTP is a gene. So these come from the database. We locate sentences that contain those two entities, and we look for factors that influence that relationship. For example, in this case, in this particular sentence, manganese is a condition. So in the original database, they didn't have these factors. With the help of this, with the support of text mining technology, they were able to add those factors to the database in an efficient way. And so now the database contains these conditions associated with the genetic, with the relationship between transcription factor and gene. And as part of this process, they are also developing a new version of the interface which I've shown you before, which will be more powerful and will allow the curators to easily locate in the text the entities they are interested in and insert them from the same interface into their database. So this was a quick overview of some of the projects in which I'm involved. Now I'm going to focus specifically on two of them, two applications. One is MedMon, the project in collaboration with Roche, where we deal with social media content. And the main person working in this project has been Tilja Ellendorf, my student. So in this project, the goals are to locate in social media discussions about a specific disease and gather from those discussions information that could be relevant in the process of drug development or monitoring. Examples, patient perceptions of their specific disease burden, or identify patients that are potential candidates for clinical trials. This is a major problem for pharma companies. Clinical trials are very expensive, and you need to locate patients that are willing to do it and that will not break up the clinical trial in the middle. And patients are particularly active in social media discussing their disease might be good candidates. So in this project, it's a collaboration with another university in Switzerland, and our partner provides this interface for downloading the social media, which is mainly tweets, Reddit, and some patient forums. These are the diseases that we monitor, at least initially, and the goal is to deal with different languages, although our main focus so far has been in English. The pipeline of processing starts from the retrieval of the data, pre-processing of the data with removal of duplicates, filtering of spam, and locate specific diseases, and then extract some specific cases of mentions in which we are particularly interested. So we start with the initial sources, and the initial filtering is done by keyword search, so it's very basic. We have some keywords that have been defined for the diseases which we are interested in, and obviously there will be a lot of false positives. Parkinson can be a name of a person, and this abbreviation PDMS can be many different things. So we need to do a lot of filtering afterwards. We start with removal of duplicates and some pre-processing steps which are very common when you deal with social media, especially tweets. You typically have a sub-language in this type of media, where, for example, you have usernames that are modified, you have URLs, you have hashtags, and you have camel case expressions, and so on, or emphatic expression with duplication of vowels. All these are modified in order to be able to cope with them better. Then we need to identify the relevance of these microposts. And for example, does the tweet actually mention a disease? Here we have Parkinson, but it's probably not a disease. Here we have joint pains, but it's probably just spam. Somebody trying to sell, to advertise some product. Next, when we've done some filtering, we want to do some classification of what we get. In particular, we want to find out if the post is about a specific patient, if it has been authored by the patient, by a relative, or by a healthcare provider. Often you have the case that the patient himself or herself cannot write a post because simply it's not in the conditions of doing it, but some relative will be, or some caretaker will be actively discussing the disease. And as part of this, since we found this was very fitting to our project, we decided to participate in the social media mining for health challenge that Graciela and Davy have described earlier today. In particular, we participated already 2 years ago, but in particular last year we participated in Task 4, which was about generalized identification of personal health experience. So if the post is about the patient actually having an experience of disease or not. In this particular case, in Task 4, basically we were given as training material two different health conditions, influenza vaccination and infection, and we didn't know what would be the condition of the test set. We knew there would be a condition to be identified, but we didn't know which one. So we approached the problem with, by training BERT classifiers on the training data. We did the cross-validation, tenfold cross-validation, training different classifiers on both of the two types. Because remember, we had two different conditions in the training material, influenza and infection. And so we trained 10 classifier for each of these two cases, but the size of the data was very different. In one case, we had 10 times more data than in the other case. So we then merged this classifier, this 20 classifier, in a single classifier using different approaches, and weighting the merging by the size of the training corpus. So the resulting classifier is able to predict whatever is the condition in the test set. And we were the best system in this challenge. Yeah. With numerous participants. Then the rest of the project, basically, we intend to bring this successful approach inside the scope of the project. But we have other aspects to deal with, annotate the diseases at the span level, and dealing with layman terminology. So the same disease can be mentioned in social media, in using words that are not the standard words used, that would be used by a doctor. Angel could be a name from Angelman syndrome. Recognizing all this layman terminology is a challenge. Then we have multi-word expressions like troubles falling asleep. There's probably some insomnia problem here. And the distinguishing between symptoms and effects of the drug. Like she was given painkiller containing epinephrine, and she has not stopped having tremors since the dental appointment. So is the tremors now the symptom that prompts her to take epinephrine, or is the effect of epinephrine? So this is not always easy to distinguish. We want also to distinguish some attributes of the patients, like the location where the patient is, or the caretaker, the age of the patient, the gender. So we want to try to classify a bit better what the material that we have. Some of this is done relatively in a basic way so far, but we aim at adding some of the methodologies that we have tested in the shared task. So conclusion of this part, we have implemented an efficient, this is agnostic retrieval of micropods, agnostic because we were able to show that training on different conditions led us to the best classifier in a different condition. Starting from condition A and B, we were able to detect posts relevant to condition C. And then we have all these filtering levels and detection that are now being implemented as part of the project. So this is all what I have to say about this project. I'm happy to answer questions later, but I will take a few minutes to discuss another application of our work. This gives me a chance to talk about some of the basic tools that we provide, we develop and provide to the community, make available to the community. And I used our participation in another shared task as a way to mention these tools. In particular, this was the task organized by University of Colorado. So Kev, I think, was part of the organization. The craft shared task was discussed at the BioNLP workshop, which was organized by Jin Dong at EMNLP in November. And the goal of this task was to recognize entities in a very large corpus, 67. So the craft corpus contains 67 full text papers annotated for using entities from many different ontologies. And as part of the task, we were asked to recognize entities in a hidden set of 30 articles. Not only recognize the span of the entities, the dimension of the entities, but also disambiguate the entity with respect to the source ontology. So it's entity recognition and disambiguation or linking task. So the traditional approach for entity recognition and disambiguation is the pipeline approach, where you first recognize the entities, for example, with a sequence tagger. You have disease here, skin, and you have the chemical here. And then in the second step, you look up these entities, these texts that you found in some dictionary, and produce an ID. In this case, is mesh. Obviously, this pipeline approach has several problems because if you fail at the first step, you cannot get anything at the second step, errors propagate, and so on and so forth. So there are different attempts to combine the two approaches. This is an example of dissertation at the University of Colorado where encoder is trained on, an encoder-decoder architecture is trained to recognize the character sequence and predict the IDs. Seems magic, but seems to work to some extent. Another approach that has been tested in the literature is to do the two tasks at the same time, having the input of each task, the output of each task used as input for the other task. So feedback between the two tasks. For example, this paper does that. The problem with this kind of entity is it's very difficult to train. It's very expensive to train. So our own approach, we have used an idea based on the previous reference that I mentioned, but we have cut one of the links. So we train only the entity disambiguation step on the basis of the entity recognition step. So it's only one step feedback. And we also tested a different architecture based on BioBERT, where we have BioBERT basically trained from two different independent models, one for detecting spans and one for detecting IDs. So these are two different approaches that we used, and basically in our participation to share task, we wanted to compare the different approaches. One big problem in this kind of task is that the set of IDs is huge. Because if you have genes, diseases, proteins, chemicals, you have millions actually of IDs. So you can actually train successfully a system that will be able to recognize all the possible IDs there. So one way we try to deal with this problem is that we analyzed with our entity recognition tool, which I'm going to mention in a moment, a large set of PubMed abstracts, like 100,000 randomly picked, and we identified the most common concepts, that is IDs, in that subset, random subset, and we used only those concepts in a pre-training phase. This was used for the BioSTM approach. For the BERT approach, instead, we use the backup model, where the idea is that the two components, the entity recognition component and the entity linking component, cooperate, and we can basically do a kind of voting on consistency between them. So, for example, the so here we have a protein, hexokinase 1, and span recognition tells me that this is a protein, and ID recognition tells me also this is a protein. Protein gives me an ID, so we have an agreement, in which case this is passed on as a solution. If we didn't have the agreement, then we would not accept that as possible annotation. So this is based or behind the scenes. What we have is an efficient lexicon-based entity recognition tool called Ogre. It's freely available. I invite you to test it. It provides annotation for different entity types. It's also very accessible as a API, so you can simply submit PubMed IDs or PubMed Central IDs and get them annotated in different formats. It's also very efficient. In a competition a couple of years ago, we had the best results. This competition tested only the efficiencies of some text mining system for biomedical literature. Now, the problem with all lexicon-based entity recognition system is that the dictionaries get old, get outdated very quickly as the resources improve. The way we dealt with that is that our entity recognition system is tightly integrated with another tool called the Biothermap, which is an aggregator of terminologies. So the Biothermap, which can also be used independently, you can find information here, takes terminology or takes several life science databases as input, or polls them, and extracts from them on the fly relevant terminology. And so the way it works is that every time you open it on this page, or link provided on this page, it will show you a page like this and check if any of the resources has been modified since the last time we updated it. If it has been modified, it gives you the opportunity to update it. This way we keep our resources always up to date. And Olga basically interfaces directly with this Biothermap, so it can always get the most recent resources. Coming back to the competition, the results of the competition were evaluated with two metrics: the slot error rate and precision recall, and traditional precision recall F1. So I don't have the time to go much into details now, but we basically compared all different configurations, not just the dictionary-based system, the BioSTM system, and the BioBERT system. And I would like to say we had the best results in the competition, but we were cheating because we were the only participant.
In other words, you have to work
To put it that way. Anyway, we used these diagrams to represent the different systems that we evaluated. Where on the bottom you have the F-score, and on the top you have the slot rate, error rate, because you want to maximize your F-score and minimize your slot error rate. And these are the results for the different ontologies, where we compare the different configurations for each ontology. And we had actually quite good results in several cases. An interesting aspect of this approach that we implemented is that we are able to predict IDs that are not seen in the training data. Because in both approaches, in one we have a pre-training phase in which some IDs are stored in the memory of the neural network. In the other approach, we have the lookup through Augur that will be able to provide IDs that are not present in the training data. For example, here we have somatostatin receptor recognized correctly as a KB entity. We also looked at the values. These are not the values overall. These are the values only for the unseen IDs. And for example, this approach, BERT, is capable of recognizing some unseen IDs in some ontologies with precision of 71. And so some results are quite interesting. This is only about unseen IDs. Coming to the conclusions now. So I presented several projects in which we use this basic technology that I also mentioned at the beginning, at the end of my talk. So in particular, I want to focus on these two tools that we provide and are freely accessible to the community, and we would love to other people use them. So one is the Bioterm app. It's an aggregator of resources that allows you to. You can also use it standalone. You can just simply select the terminologies that you need and download them in a CSV format and use it with your own text mining tool. And Augur, which is an efficient entity recognition tool using terminologies provided by Bioterm. And I think we have shown that we can make good use of state-of-the-art technologies for specific approaches in two shared tasks, obtaining very good results. And we are applying these methodologies in various projects and with different type of text, literature, clinical records, social media. And with this, I conclude. Thank you for your attention.
We have time for some questions.
Yes.
So the Bioterm Hub and the update, I wondered, sometimes ontologies I know get worse, and sometimes they might want to experiment with different versions. Could you talk about that?
Well, yeah, let me go back. So our goal is to use the most recent version of the ontology. We hope that the providers are making good work. But of course, you could save a previous version. Through this interface, you will get the latest. You could have used the interface, say, a month before, 2 months before, and got the previous version. Otherwise, we don't provide a way to go back in time. You have to go to the original resources. Sorry, it's already very complex.
Would it be possible to do that? Would support some experimentation you couldn't do otherwise?
Well, the problem is that each resource has its own structure. It's very, very difficult to maintain different resources. You have to different way to get downloaded, a different structure of the result that you have to parse in order to get the same structure at the end of the meal. So for each of them, it's a lot of work. Adding a new one, I mean, we can do it if you ask us.
It's just a version, right?
Versioning, it's not something we want to support. I'm trying.
But you already have that as soon as you left the updates. Maybe I don't understand.
Well,
the update does.
Well, the update simply takes the new check. The update button appears if the resource has been changed since the last time we downloaded. If you don't press the update button, what you get is the previous version. But we don't give you a reference to which version was it. You would have to check with the original resource. Yes?
Precise question about deadline application.
Again? Deadline?
Deadline.
Yes?
I wondered how normalization is performed. How do you attach the term of the text to the mesh term? What is the method for doing that?
Well, again, we use the Augur for this. It's a simple dictionary lookup. There is some flexibility, minor flexibility, in the sense that some minor modification of the terms will be identified, like an hyphen, not an hyphen, capital letters, different capital letters. But if the term is completely different, we will not find it in this particular kind of approach. And by the way, UMLS has a subset of German terms, so we look up into German terms. This is also a possible effect, and nice effect is that we can then find the corresponding English term. by finding the concept and
Okay, yes,
so you will
translation.
have the term, find the concept, find the corresponding English term.
Okay, let's thank our speaker. Our next speaker, Mariana Neves, will be coming to us via Skype.
Mariana, would you turn off your mic? Mariana, would you turn your mic off? Mariana? Would you maybe I can, yeah, do it. Okay. So Mariana's presentation will be played. It's slides with the voice, and then she will take a question through Skype. It's a bit challenging, but let's try.
Good afternoon to everyone at BLA in Tokyo.
Can you
I'm
hear it?
Mariana, and I'd like to present my remote participation in BLA 6. And I tell you about our experience of integrating paper notation ecosystem in our Smart Figure project.
Can you hear it?
Good afternoon to everyone at BLA in Tokyo. I'm Mariana.
This is the maximum. Can we raise the volume of this room? This is the maximum. Okay.
Good afternoon to everyone. First of all, some words on the motivation for our work. In our department at the German Federal Institute for Risk Assessment, we carry out research in the field of finding alternative methods to animal experiments. In particular, my research consists in mining the scientific literature, currently Medline, for such alternative methods. These alternative methods are based on the so-called 3R principles, namely replacement, reduction, and refinement, as shown in this slide. Replacement aims to rely on in vitro methods or non-vertebrate animals instead of vertebrate animals such as mice, monkeys, or fish. Reduction aims to reduce the number of animals as well as to acquire as much data as possible from the experiment, as long as it doesn't imply in more suffering for the animal. Finally, refinement aims to develop methods or housing conditions that will cause less suffering to the animals. The scope of our specific project is to develop a search engine to support researchers for finding these alternative methods. Following the statements of the German laws as indicated in this slide, there are two important address the same research question inputted by the user. Currently, an existing publication from Medline. B. The alternative method should comply with one of the 3R principles. Currently, we are addressing only the replacement principle. As an example of an input document in our system, I show the research question addressed by the publication aspect A, that is, mutation in a particular gene that could cause Parkinson's disease. Given this publication that describes an animal experiment on mice, as indicated by B, the researcher might wonder whether there is already an alternative method for evaluating the same research question. Here I show a potential alternative method, since this publication also addresses the same research goal, that is, mutations on that particular gene as code for Parkinson's disease. However, the method described in this publication relies on threads, as indicated by the B aspect, and thus it does not constitute a valid alternative method that should be returned by our system for that input document.
Jake, can you hear? Okay.
Here I show another potential alternative method, since this publication also addresses the same research goal. Again, mutation in that particular gene as codes for Parkinson's disease. But this time the proposed method relies on C. elegans, worms, which is a species not protected by the European or the German laws, and thus a valid alternative method to the input publication. In order to mine this publication, I developed a workflow that relies on various resources and tools. As shown on the left, we are annotating a corpus for the identification of the methods for training the classification methods. This addresses the aspect B. We are also building some use cases to address the aspect A with respect to matching similar research questions. Some of these use cases have been already used for evaluation in a work that we published last year. Please check reference 1 below. Regarding the methods in the middle of the figure, we rely on set classification for the identification of the proposed methods, aspect B, and document zooming and text similarity for finding similar research questions across publications, aspect A. As for the external resources, as shown on the right, we rely on Medline for a pre-selection of similar documents. When showing results to the user, we highlight relevant entities which were automatically extracted by some tools, for instance, disease chemicals and species from Togotv Central and cell lines from Cellosaurus. Finally, I'll refer to our use of pub annotation ecosystem in the next slide. Regarding our integration with pub annotation, we store the discourse annotation for zones, such as background, methods, results, etc. These were either automatically extracted by a argument side tool or are the original ones provided by Medline. We store them in two separate repositories. We use text AE to highlight annotations retrieved from Togotv Central. Prior previous real-time align them in pub annotation. We are currently trying pub dictionaries for the extraction of cell lines contained in Cellosaurus. We create a dictionary in pub dictionaries, as shown on the left, and an annotator in pub annotation, as shown on the right. However, we still have some issues with respect to the precision of detected entities, since many false positives are usually detected. Finally, there are some issues that we would still like to either discuss or collaborate with the pub annotation team. Queries to pub annotation will still take some time, given that we need to query up to 200 publications on real time. Thus, we would like to discuss solutions to speed up this process, such as parallelization of our queries or retrieval of multiple publications in a single query. Further, we would like to suggest support support for document-level annotations, which is actually a feature not supported by many annotation tools, as we recently noticed while preparing a survey on annotation tools. Please check reference 2 below. Finally, Biomedical provides built-in annotators for some services, and having one for the recently released Data Central would release us of query an additional resource and align them on real time. That's all for now. Thank you very much for your attention, and I'll be glad to take some questions.
Okay. I hope now Mariana can take some questions. Mariana, can you hear me?
Yes, do you hear me?
Yes, yes. How long do we?
We have a minute and a half.
We have a minute and a half, so maybe one or two questions.
We had some trouble hearing you. Would you like to give like a 3-sentence summary, maybe?
A 3 what?
A 3-sentence summary of the paper, just because we had the goals, methods.
So the goals that we are using for annotation is our support for our search engine. So, well, I have a document storage, so annotation storage for some of the annotation that we are extracting automatically. So instead of using having a copy of PubMed and storing our annotations also locally. And for the moment, I decided to use Pub Annotation for that. We are also trying it, as I showed in my slides, for some cell line detections, also for annotation alignment when I use annotation from other sources such as Data Central. So this is like a support for this search engine that I'm building for this use case that I explained in my slide. I'm not sure if the use case, if the problem that we have was clear, or whether you need some more explanation.
Okay, Mariana, thank you for your presentation. I'm turning off the Skype now. So Mariana, during the hackathon, Mariana will be working on this project remotely, and maybe she will share the progress with us. It's a bit experimental. Yeah.
We all know that technology will solve all problems. It's always good to question our assumptions. Our next speaker is Robert Bossy.
Kevin. Yeah.
So I will present you a project for the integration of 2 data sets into Pub Annotation, and also an evaluation plugin to Pub Annotation. So this work was proposed by myself and Louise, who is there, and we will be working on that here. So we are both at INRAE, which is an institute for research on agriculture, agronomy, and food science and environment. So the objective is to integrate 2 annotated datasets, manually annotated datasets that have been proposed to the BioNLP OpenShare task at the end of last year. And so these are shared tasks for the information extraction in biology. The evaluation tool
which is associated to both datasets. We want to integrate it as a Pub Annotation plugin because recently Pub Annotation has a framework to plug in external evaluators. So with doing that, we want to reach a wider audience and also improve the interoperability between our datasets and other datasets that are inside Pub Annotation. So the first dataset is bacterial biotype, which concerns the microbiome diversity and which is important in health science, food science, food processing, but also environment science and so on. This is a full information extraction task which contains entity recognition and normalization and also relation extraction. So we have 4 types of entities that has to be that are normalized with the ENCBI taxonomy for the microorganism and normalized with the ontology for habitat and phenotypes. So we have 2 types of relations between microorganisms and habitats and phenotype. So this is what the annotation looks like. What I can say is that there are microorganisms and geographical entities which are rigid designators, whereas habitats and phenotypes are more like noun phrases. The CDEV dataset is a genetic and molecular mechanism. It's about a mechanism for the plant seed development, which is very important for the study of improvement of crops, for the improvement of crops and their resistance or their efficiency. So we have annotated extracts from food text articles, and this is a very complex annotation with more 16 entity types and more than 20 relation types. So the annotation is really, really more complicated and very dense. So we have genes and proteins and anatomy parts of plants and so on. So the plan for integrating the datasets, first we have to develop a format converter between the BioNLP-ST format to Pub Annotation. So this will be done in Python, of course. And we have anticipated some problems like the URI design, which we want to design very intelligible URIs, but also the representation of complex structures like discontinuous entities, the entity normalization, and for the CDEV, we have n-array relations. How do we plan to check the quality? We will check that manually. We will convert and then upload the annotations on PubMed and check for some for a sample of documents and see if the annotation is correct. We already identified some problematic documents where we have these representation challenges, so we can check that. The evaluation tool, we have a single evaluation tool for bacteria, biotype, and CDEV. So we share a common evaluation framework which differs from the data sets, but also the annotation schema. But basically, we have the same annotation evaluation pipeline. So the service is already available as an API and as a user interface. The submissions for the moment are in BioNLP-ST format, so we will have to convert to build something that accepts the Pub Annotation format. So this is what it looks like. We upload the predictions and it gives you a lot of scores. So to integrate this evaluation tool, so we'll have to develop a format, a pub annotation format parser, of course, and adapt the API to the pub annotation plugin protocol. So we'll have to look into the documentation a lot. So the quality control, how we will check that the evaluation tool works well into pub annotation. We will convert and evaluate participant submissions and submit them and try to reproduce the official scores that we had last year. So as a side note, participants explicitly gave us the permission to publish their submission. So here are some links that we will use and that you can check. So the both datasets, bacteria biotopes, CDEV, the evaluation tool, its sources, it's an open source software. And we already started by an PST parser that we will use it to convert into pub annotation. That's it. Thank you.
We have time for a few questions. You mentioned some papers with problems. Could you talk about what some of those were?
The problems or the papers? Problems.
The problems with the papers. The papers, so the rest of us can skip them.
Well, I mentioned them actually. It's discontinuous entities. Sometimes the entities are not in a single span. We see that a lot when we have conjunctions, copula. Also, the normalization, we are not absolutely sure how to represent them in pub annotation, as well as NRE relations. NRE relations, we will have to reify the relations because we cannot use the binary, the simple binary representation. That's it. We know where to find them in our corpus. We know where are the discontinuous entities, normalizations, and NRE relations, so we can check that.
Other questions? So a question about those problem sentences. Do you think there would be a value in putting together a corpus of problem sentences for evaluating annotation interfaces? It's good for evaluating parsers, actually.
Yeah, why not? Never thought about that. I know that another problem is, for example, in the normalization, some entities have several normalizations. So this is another problem. Yes. Okay.
50 seconds. So that might be a really nice blog project that a lot of people would use.
10 seconds. Just a question on whether you use any of the geographic location or for the bacteria biotope. So you integrate that information.
So we will integrate the name entities. In bacteria biotope, we don't normalize the geographical entities because there are not so many of them actually. There's just a few, and yeah, we will integrate them. They will be there. And also we are not really. Our intuition is that is that geographical entities can be normalized, maybe with your names, but we don't know that we are not. We don't have an expertise to affirm that, definitely.
I have that system.
Okay.
If it's of interest, we can talk.
Okay.
Let's thank our speaker again, and the next speaker. The next speaker is Jake Lever.
Right, your talk
Yeah,
is...
send you a link.
Link. Sorry.
Thank you. Okay, I'm Jake Gleaver. I'm a postdoc at Stanford with Russ Altman, and I'm going to tell you about extending the TextAE annotator, which is a tool built here. And so I kind of want to briefly explain why I'm interested in doing it, and then the specific extension feature I'm interested in adding, which is non-contiguous entities. So I'm kind of a knowledge-based construction person. I'm interested in building quite specific use cases of knowledge bases for cancer and kind of personalized medicine. And up until this point, I've been using kind of very rudimentary hack-together annotation platforms. Kind of, for those people at the back, you won't be able to see this, but it's basically a website that shows a single sentence with a, is this sentence talking about the thing we're interested in? Yes, no kind of button. And it doesn't lend itself very well to making corrections, to fixing kind of entity annotations. What it's really good at is allowing you to annotate things really quickly and kind of go through things and get a large number of annotations. And so most recently we used this to build a pharmacogenomics knowledge base. So that's an associations between mutations and chemicals. If a mutation affects the kind of metabolism or dosing of that chemical, that's really interesting to us. And I'm working with a group that's been building the PharmGKB, pharmacogenomics knowledge base, for the last 20 years, and they now want to use kind of NLP to help them curate it a bit further. And so yeah, we've built this thing, but the challenge is that there are mistakes in it, and we want to figure out how do we go around correcting them in a nice way. How do we give kind of annotation tools to a team of curators that normally are doing like document level curation and aren't so used to working with some of the more intense annotation platforms out there, so they can go in and fix things themselves, and I'm not constantly like fixing things for them. And so the tool that I like hunting around for tools that I thought might be appropriate for this, I'm interested in kind of figuring out how we could get TextAE to work with this kind of problem. So TextAE is a tool developed here at DBCLS. Jin Dong Kim and his colleagues, and it's like a nice web component that you can plug into different things, select spans of text, and kind of click between to create entities, and a whole bunch of different bits of functionality. So in this case, just an example of selecting two proteins and creating a relationship between them. It's part of the kind of pub annotation ecosystem. So it's the default viewer for pub annotation, and then you can use it for editors. But what is kind of super nice is just how you can integrate it with other things. It's a Node.js element, component, and so you can just kind of plug it in and pass it a data set, and it just visualizes it for you, which is super nice. But one of the things that I'm particularly interested in capturing, which we're just like not done at all well at, is the concept of non-contiguous entities. So entities where there are multiple spans potentially separated by a bunch of words. And most tools don't really support them very well, but they come up quite a lot, especially when you're trying to extract information and lists appear. So we have an example here, a sentence from another previous project to do with associating the roles of different genes in cancer. This gene has been identified as a tumor suppressor in a whole bunch of different cancer types, and you get a list. And the issue is that lung is not a cancer type, lung cancer is a cancer type. And so if you're trying to match things against, you really need both the word lung and the word cancer. And so you need a way of representing the fact that those words aren't next to each other in the text. And so, just before we go to that, what's quite nice is that the pub annotation file format actually supports this, but at the moment TextAE doesn't support it directly. So I'll show you kind of one way of representing it at the moment, which it can, which is not super elegant. The idea is that you have two separate entities, so lung is an entity, cancer is an entity, and you create a separate relation between them. And I mean, technically that's fine, and you can do some post-processing to fix it, but it's kind of a bit ugly, and especially if you hand a tool off to someone that isn't like a trained annotator knows why this is a thing, they'll just be like, oh, I'm fed up with this. So the idea is, can we implement the kind of more elegant way of doing it in TextAE, which aligns with the kind of the actual supported pub annotation format. And so the hackathon goals are, first of all, can we get TextAE to visualize some non-contiguous entities, just give it a sentence like the one I just showed you, and it actually shows it nicely. We'll see if that's doable. If that's doable, can we actually add some functionality so you can start adding your own entities, add a new span to an entity, and then obviously can you actually save all of this back to the original file format. And in that short amount of time, thank you very much, and thank you to the travel sponsors and the organizers here.
We have plenty of time for questions.
It was super simple. Excellent.
Have you considered for that problem, the non-contiguous entities, using the links that already exist, like modified, like the grammatical links? So you get cancer and then find the modifiers for it already.
Oh,
so
sure.
The system's already there.
Oh, no, in terms of actually extracting them, that, I mean, it's not a hugely challenging problem for the list format. It's more for being able to visualize it and just look at it in.
I was just thinking on simplifying the life of annotators.
Yeah.
It's like, why would you ask them to annotate if it's something that can be derived automatically?
Well, it's sometimes you'll get, and this is like a weird one. So specifically for cancer types.
For example, I mean, it can be for
yeah. So sometimes you have to go in and correct things where people call it like a carcinoma versus a cancer, and so if that's in a list form, then you have to be able to go in and edit those to correct it, and so that's why you need an annotator that supports this kind of thing. Where it would say like lung carcinoma and you want it to be lung cancer or something, but it's across a list. You basically just need to be able to look at these things, and that's the challenge. But actually extracting them, it's not supported by a lot of tools at the moment, but it's not a hugely challenging problem for the list.
Other questions?
Okay. All right. Thank you.
Thank our speaker.
So now please enjoy your coffee break, and please come back at 4 o'clock for the last session.
教員側が嫌がるからやってくれないんですよ。
同意書取ってます。
あれが本当に大変な作業です。毎回倫理委員会でしてその話はちゃんと言えなかった。いい話だけ言いましたので、その倫理委員会の話は入ってない。
そういう嫌な話は入れてない。
100ページぐらいの申請ですよ、倫理委員会。じゃあ、もう離れられないのでしょうがないんですけど。役に立つのはいいんですけどね、その病気によっては治らないので、診断できても治せないっていうのが辛くて、ちらっと言ってますけど、発達障害のが入ってて、
ただ療育があるじゃないですか。
一応でそれが話を聞いたら、若い方がいいって言われて、何歳ぐらいかって言ったら1歳から3歳ぐらいって言われて、言語処理にはならない。
Let's get started. Please come back to your seats.
彼らはアイトラッカーで目の動きを追ってやってるそうです。それはできるんですよ。なんか目の動きが違うらしい。
Welcome to the
で、言語
last
処理の手段は
session.
ないと。
This session will begin with an invited talk by Yoshinobu Kano. He will talk about Japanese medical NLP. I believe it will be a rare chance to learn what is going on in Japan with this interesting subject. Let's welcome Yoshinobu Kano.
Thank you very much. I'm very happy to see all the friends of the Biomedical people here again, and say hello to the DBCS all the colleagues. I want to talk about my own project, not for all of the Japanese projects. So this is just for my own project only. I'm currently tackling on the automatic diagnosis of the mental diseases and some processing the EHRs. So I want to talk about these things today. Well, first of all, I'm currently here. Probably you don't know, but here is a so-called Mount Fuji here, and we have the Shizuoka prefecture. And almost all the people is just passing this prefecture to go into Nagoya or Osaka without dropping off. But if you have any interest in our city, there's nothing there, but you can drop off on my city, Hamamatsu here. It's a westmost town, this prefecture, so it's near to Nagoya, 1 hour and a half from here. Well, anyway, this is the thing. So this is self-introduction. I'm Yoshinobu Kano, and I'm formerly from the Tsuji lab of the University of Tokyo before. And after doing the JS Presto Sakigake 1 on DBCS, and I'm currently in the associate professor of the Shizuoka University. And I want to talk about the medical things today only, but my own interest is for the NLP in general. So I'm doing research of the spoken language and written languages, and I want to create some human-like NLP system as a goal, but for the medical things, it's more application. So it's not really for the psychological things today. And this is a kind of ongoing my own projects list of the things. Actually, so many projects going on. I can talk about these red ones only today, but I'm tackling the legal NLP to solve the legal by examination in Japan to make the automatic court judgment system. Or I'm doing some automatic generation sentences to play the WoW game. It's called Mafia. Or catch copy generations for the advertisement copies, or news headline generations, and so on. And I'm going to talk about these one today. Before doing that, this is another small one before going. Probably some of you may have interest in. I'm trying to create a text mining system for the neuroscience papers. If you see the neuroscience papers, they describe about there is some function in the brain and the coordinate is something. So we want to extract coordinate function and some experimental condition mapping. Then we can make some inference of the possible network in the brain. And I want to compare with so-called, what's the name? Some large network in US, they are trying to extract all of the human brain, cutting off automatically and make the physical neural network. And if you can compare with the paper mining result with such actual result, then we can find some inference of the possible network. That's one of the goals of this project. And finally, I can show such things in the service. Probably we can release this system in this year, because this year is the end of the project year. We have to release. It's obligatory. Well, this is a CREST project of the JST funding. And medical documents. If you see the medical documents, I think it's same in other countries, but Japanese medical documents are same in the sense of the broken language. The doctors are very, very busy, so they write some broken languages. And even if they write quite a good language, the contents are not so easy to interpret, because there are some expressions, like in this case, what's the name? This is a symptom for when you are sleeping, your breath is stopping. That's a symptom name. And you have to find the symptom name from the expression of the language. It's saying breath noise getting worse in the night, breath stops. But it's a one noun, proper noun. So we have to find what is the correspondence between the expression nouns. Probably it's quite common for your research as well. But if we can do such sort of thing, then probably we can make some extraction of the documents of the electronic health records. One of the projects I'm involved in is the JPL project. This is a AMED-funded project for the physiological things. If you have some cancer, then your cell will be picked by the doctor. Then it's sent to the physiological people. Then they have some microscope check. Then they can find, oh, this is cancer cell, or this is just healthy cell. And they have so many photos with the memo, textual reports with the photos. So we want to find what is the reference from the text to the photos, because in the photo you have so many tens or hundreds of cells at the same photo image. So we want to find which one is the cancer and which one is a healthy cell. If you interpret the text, we can narrow down which one is which one. So that's the final goal of this project. But before going to do that, we have to de-identify the text. It's same in any country, I think. We have to de-identify the contents to anonymize from the patient's information. It's not so actually easy to do that because in Japan, they require, the government requires to make de-identification before using the data, but there is no definition what is the de-identification in the Japanese government. So we really don't know what to do. And the final thing happens is each hospital decides their own criteria. So sometimes, it's a proper noun, or sometimes, because it's an age, it should be hidden, or sometimes it's sex, or sometimes it's a history of the disease itself. So first we have to define what is the identification, but at least we have to hide person names, or ages, or hospital names. So that's the bottom line. So we are trying to do this by human annotation and trying to learn from the human annotation. And then one of the projects is summary generation, because in Japan, the doctor is required to make summary when the patient retired, exits the hospital, or the patients die. So they have to summarize the past history of the records, but it's just cumbersome for them because it's just summarization. So they asked me to create automatic summarization system to help doctors. But actually we tried this one, but we found that the summary is not really summary in this case. Patients sometimes write down something new finding in the summary. Like when we think about the past medication, probably we have to do that rather than the actual Medicare. In that case, it's not really summary, but it's finding. So we cannot make extractive summary from the EHRs in this case. It's actually another very difficult problem. And another same problem is here because we don't know what is the good summary. Actually, doctors don't know. So we have to discuss with the doctors to define what is the gold standard summary, but it's still very difficult for them. But we are still doing trying to do this. And we collaborate with the NHO hospital. It's a national hospital organization in Japan, and they have 50 hospitals in Japan. And they are already collecting a huge amount of the EHRs from all of these 50 hospitals in the same format. And they already storing, I think, a couple of millions of the records. So we can use these records to find something. And we are currently trying to find side effects of the cancer medicines. Because if you have some cancer, then sometimes you have to select to do Medicare by the chemicals. In that case, side effect is a large problem because this cancer medicine side effect is quite strong sometimes. So we want to find which person could have strong side effect by finding the past history. This sort of person, patient, could have some large side effect for this medicine. That's possible. But in that case, we need NLP because side effects is not written as a numerical value, but it's written in the free text part. So we have to find this patient had some side effect in this day, and with the numerical values of the medicine, we can find, this is a medicine here, then they have some side effect, then the personalization of this patient is something, and find new patients could be bad for some specific medicine. So that's one of the projects I'm going on. And so I'm going from one to one. It's again another one. It's one of the main topics today. I want to talk about the mental disease diagnosis from the conversation, spoken language. This is one of the JST Quest project. It's a large grant-funded one. And we are collaborating with the Keio University Hospital. They are the mental disease people. And they are recording many patients' conversation and send us as a records. And then we transcribe everything into text and make annotations. Then using these data, we trying to infer which person could be like depression or Alzheimer's disease or some anxiety. And currently we record, it's too old, but currently we have 300 hours of records already. I think it's one of the largest spoken language corpus in the world. And we are annotating, transcribing all of these records. And part of the records are annotated by some special annotations. I will show you later. And, okay, the problem is, if I make a submission of such paper, we normally ask these things. Will you make your corpus publicly available? It's a large problem in the medical processing. In Japan, it's never happened because hospital doesn't allow us to make anything public. Actually, they are very strict on the publication. So we have to say this is not really reproducible, but it's because of the personalization information, personal information problem. However, it's I think same in all over the world, right? I think China has some specific another situation, but most of the countries are quite strict on publishing the records of the patients. So it's not really possible that we are storing the data. So we can use the large corpus if you are the collaborative researchers, right? And another problem, another question frequently asked is it large corpus? From the NLP point of view, it's already 300 hours. I think it's quite large as a spoken language, but if you transcribe into text, the size is not so large. I will show you. That's one of the another problem in this project. And but when we can do this automatic diagnosis of the mental disease, I think it's very useful because when the doctors make the diagnosis, it's very costful because they have large, higher salary. But if we can do automatic, it's quite good. And another problem is, it said that one in 4 people in the world has some mental disease. That means probably here, I think 20, 30, 10 or more people should have mental disease or related things. That's statistics, right? So if it's really possible, then it's very useful for all of the people. Right. And if you can find some disease before you are getting real disease, it's much better. So that's one of the aim of our project. And corpus science is called underpin. I don't remember some abbreviation, but it's called underpin. And because I want to show you the image from all the advertisement video. It's a JST funded project, so they create some advertising video. I'm sorry it's in Japanese, but I can show you in English by my own translation. So it's, I have 1 minute to show. Because recently my PC crashed, and I moved all the things to the new PC SSD, but it's still not all of the information was recovered. Video. Where is the video? Video. Okay. And of course I have so many. I found one. But it's just some images. Well, if you are Japanese, you can read the letters, but I will show you in the English. This is Keio University Hospital. It doesn't make anything but the hospital building. And inside the building, they are recording all of the conversation between the patients. Patients are sometimes not really patients. It's healthy or some disease. And the psychologist, this woman, is asking something within this interview. And the interview consists of 3 parts. The first part is question answering. So she is asking some list of the question, like how do you feel today, or what is your family, that sort of. It's around 30 minutes for the question answering. He is a doctor of the mental disease in Keio Hospital. The point is, it's the only disease we can use NLP in the entire symptoms, because mental disease are diagnosed by the doctors using the word conversation only. So it's really NLP program. So there is some conversation. Then, of course, it's records of the voices. So we are transcribing all of the things into text, and then make some machine learning to infer what is disease or it's healthy. This is our campus, and this is my lab. And I'm asking my students to transcribe all of the records. Of course, I'm paying the money. This is because the data is personal information. We cannot send it to the Google Cloud, right? So we have to do in-house. the other things are just Japanese science skill. So this is what's happening in the backside. So after these things, we now have 300 hours of records and all the Japanese transcription there, and we have annotations like this. This is a conversation annotation, one of the famous Japanese annotation style. It's really quite precise. We are doing some annotation like here is stretching of the voice, or here is pause of the voice, or this is a tone raising, or here is filler, or here is some special expression, or the saying is just stopping inside the word, or sometimes some subjects are laughing but speaking something. So in some annotation, he is laughing and speaking something. Or some people are sometimes singing and speaking. Then it's also speaking. So this sort of transcription there. And using such annotation, we now have this sort of data. It's a bit old, but it's a more 50% more now. And we have healthy people, depression, bipolar disorder, and schizophrenia, and anxiety, and dementia. So we have 5 large diseases and healthy people. And we can do one versus less learning by SPM to infer what is the disease of the specific subject. And if you are NLP side of people, you can easily find how small these subjects are. It's too small to make some machine learning. That's a large problem. And the interview is consists of 3 parts. The first part is, as I said, is question, answer, and free talk. The second part is storytelling. You are asked to tell Cinderella, really, just Cinderella. Then some patients starts talking about quite a sad Cinderella story, or some patients may have a depressive Cinderella story. Or some patients are very happy Cinderella, or sometimes not Cinderella. That happens depending on the person. And the third part is picture explanation. I show some picture to explain what is the situation. And picture consists 3 persons, and they may have some specific relationship between, like one, they are friends or they are not friends, or they are talking something. And they have to infer such things by using the cognitive function of the brain. So if you have some problem in the cognitive function, then it's very difficult to explain such pictures. So we are asking these things. And totally we have 1 hour for 1 visit. And we are asking the same patient to come second time or in the maximum 5 times to trace what's the changes between the time. Okay. And these are the features we have extracted from the corpus. Because of the number of the subjects is very small, we are doing quite classic things. So we parse the sentence by the parser and find what is a part of speech and what is some specific case laws. Because in the case of Japanese, the case laws are explicitly marked by the Joshi particles. So we can find what is the case laws, how many times they said what sort of case law. And it's very related to the cognitive function of the patients, because using subjects are easier, but using objects are a bit more difficult. So we can find how many objects can be used by some specific disease people. Or the response time, or formants, or fillers, or these are audio, not linguistic features. And using all of these features, we have tried to infer which person is which disease. And this is again a bit old result. I think it's currently around 80 in the F1 score. 80 is not so bad, but not so good. But doctors are saying 80 is fine to use in the actual medicine to help doctors. We cannot replace the doctors. There is 2 reasons. One reason is this value is not so good to use as a doctor. But another reason is who can be responsible for the result is a large problem. So we have to ask some doctor to take the responsibility instead of us. So we are asking doctors to use this system as just a helper system, not the doctors. Here is some finding from the analysis. If we see the contents, we found longer sentences are difficult by the disease patients. It's probably, of course, because the longer sentences may have complex sentences, like less conjunction or a variety of number of vocabularies. And depression people, it's very famous in this field, but they tend to insist himself. And so they use many subjective case mark. I mean, they are using fast pronoun, normally, frequently. So we can find the depression people by just counting how many subjective case markers there. And another thing is dementia. Dementia decreases all of the ability of the human intellectual things. So in this case, they tend to make more mistakes or using many dictionary words. Dictionary words are used for the fillers in Japanese. So like ano or kono is too many times. That or this. Or a few contents words because they probably forget the words to say and they use more smaller vocabulary. And it's quite a contrast to the healthy people. And another thing is it's very higher correlation between these dementia people, but the higher average acoustic volume is there. It's just because probably their ear is bad and they speak larger volume speech. But it's very large relationship here. And schizophrenia, probably you know it's a sort of a complex disease. You may have some, how do you say, some not real virtual things inside your brain, right? So we have to find whether they are saying something with evidences or not. It's very difficult to extract. But probably some sort of relationships are there by finding how many case markers of ni is there. Ni is a tool marker, so it's a by something. So if you find how many by something marker is there, and if it's less, then probably they are this sort of disease. We find such sort of relationships. It's not so good correlation, but some correlations are found here. So this is a summary for this project. We are currently still increasing the number of the records. So it's going to finally 500 hours. I think it's a world largest corpus in the spoken language and this disease people. And probably we can make 80+% of the accuracy finally. The problem is whether this is really useful or not. I think it's useful for the doctors, but we want to make use of this one for the general people. So if you don't say it's medical, but it's for healthy, then we can make use of this system to the healthcare domain to automatically, like a web service, you can upload your voice. And we can say, oh, you can be disease, some sort of depression. And we are also trying to do written language disease findings there by using Twitter talks. And if you really possible to find the disease from the Twitter, then if you make some tweet, then some people will ask you, may I ask you to come to the hospital? That could happen. So that's one of the final goal. And because our goal is to make the pre-disease things to find. So before going to real disease, we want to find you can be some disease in some years. That's one of our goals. So then the world can be, our government can save the money to make the Medicare efficiently. The problem is, when I'm doing this one, I found that I myself can be one of the disease because the features are quite common. So these features are, I can find, oh, this feature is something correlated with my own characteristics. Actually, there is some specific feature of the speech speed. If the speech speed is high, there is some correlation with the depression. So my speech speed is a bit too high, right? So probably I have some correlation with the depression. But it's just a combination. So it's not just one single feature can be correlated with the disease. But I think almost all of people could have some tendency for the disease. That's actually a very essential problem because even the doctors don't know what is the criteria of the mental disease. They don't agree sometimes. So we want to create new criteria for the mental disease by this system. And this is spin-off of the same project. We apply the same thing to the ASD, Autism Spectrum Disorder. Probably you know, if you are Japanese people, it's called one of the Hattatsu Shogai, developmental disorder. And this is actually not really disease, it's just a personal characteristics. So we cannot change the personality, but we can train the people to adapt the social relationship. And here is a famous ADOS test. This is the most famous ASD criteria by humans. So if you can be entitled to ADOS expert by some examination, then you can make some examination on the patients by 1 hour or something to ask like, please assemble some puzzle, or let us talk something, or please explain some picture. And they can write some rating. And if the rating is more than something, it's a diagnosis as ASD. And we have we have records of such examination by the hospital, the Hamamatsu University of Medicine. And they recorded around 1 hour records per each patient, and totally 40 or around patients are recorded. So we use the same system to apply the similar thing to the ASD. This is the statistics. So we have 32 subjects and 25 men and 7 women, and totally 500 minutes. And the ages are quite ranging from the younger to the elder. And use the similar annotation features. And again, I asked the students to write down all the transcription and make annotation by hand. And here is ADOS scores. The human experts of ADOS make scores on different criteria. Like here is a large category, communication, and under communication category, they have 1, 2, 3, 4 different items. This is like a stereotyped use of the words. Here is a conversation, how normal the conversation is. And here is DGS or AGES. And some items are from the images or videos, because like gestures are fine, or they make some emotional gestures. So in this case, we cannot directly infer such thing by NLP only. But some relationships and correlations are there. So we can infer all of these scores by NLP, and we try. And again, use the same picture, and here's the result. It's a bit difficult to read, but because the humans should answer very correct rate with the gold standard as an expert. Like if the actual gold standard is 0 to 5, then they have to find, okay, this is 0 to 5. And if this is acceptable error by human experts, and if it's smaller than this one, then we can say the system is almost similar to the experts. And it's for many items almost similar with the experts. So we can say that our system is already with the experts level to infer the ADOS scores. We found some remarkable features. One more thing is the demonstrative vocabulary. They use demonstrative so many times, probably because I'm not sure, but the ASD people may want to point something frequently. And this is also an interesting thing. The people ASD people have less laughing, probably because of the lack of the sociality. They cannot make the empathy to the other people, and they cannot laugh at the correct timing. It's very difficult for them. And of course, they have non-clear words. And I think it's not specific to Japanese speakers, so if you can record your language and send me, then you can try this one. If you transcribe and make annotation by yourself. So, this is a conclusion of this part. We tried this one, and I think it's better than the mental disease ones, probably because we have more precise data of the human experts, and because it's 30 patients for the same ASD patient. That's the reason why we are doing the better one than the mental disease in general. So, probably because I skipped so many things, it's all the things today, but if you want to ask something in detail, I have so many slides, so please ask me. Okay, so we have, it's plus 5 minutes, or just 2 minutes for questions.
Actually, we have some time because one speaker didn't come, so we have some time to take some questions. So please.
I'm curious how much do you rely purely on the transcripts, or can you also use the sound directly? Because you would expect that there would be some features that are maybe, I mean, I know you try to capture them in the transcripts, but it can still be difficult. It might be very obvious from simple computational analysis of the sound itself.
The transcription, I mean the
Can you repeat the question? So the question is, do you rely purely on the transcripts? Or might you be able to actually extract interesting features from the sound itself, using that as input for the classifier?
The quality of the transcription is quite good. But if you rely on the transcription only. I think the features are not sufficient. So we are using the audio speech features as well. And to tell the truth, the audio features are much more effective than the text features now.
I have a question about the accuracy of the predictions for
mental
the first ones.
diseases.
Yeah. What is the accuracy for the doctors? Because in many papers about mental diseases, quite often there is no agreement between
That's right.
two doctors. So
that's dangerous thing to point to the doctors because it's actually it's not so good to say to the doctors. And they say, okay, we are very good doctors, so they can agree. But some doctors are not so good, so they don't agree.
There's the standard test for dementia.
Yeah.
MMSE and anything.
Yeah, they are doing all of these tests.
You correlate to the scores.
We are not measuring because correlation is not so good. It's just binary classification. That's fine. But if you say the scores, then it's not really correlating so much now. Actually, they are doing all of the tests, the famous ones, like the MMSE or other things. I don't remember so many things.
Could you talk about what you... Sorry.
He has his own microphone.
Go ahead.
I'll keep this one now.
About baselines.
My comment was in this field it's very hard to do anything NLP. I've done some work on using NLP models for determining cognitive decline. Neurologists are not easily impressed. When I told them and I could detect the Alzheimer's patient with like 87%, something like that, like I can detect an Alzheimer's patient when they walk in the door. It's like you don't even need to hear them talk. So selling the research in that area is pretty hard. I think the objective needs to be differently, and it has to be hand in hand with correlating to the standard tests. Otherwise, there's like...
Yeah, I agree.
Okay.
So I think these things are for the information science side. So if I submit this paper to ACA, then I have to say these things. But if you submit to the medical people, then rather we have to say what's the finding, like these people have some characteristics. I think they want to know these things rather than the numerical evaluations. Kevin?
So actually it's a version of my question, which is what is the baseline here? And sometimes, so to give an example of why I ask, I worked for many years on suicidality, and I don't know if we ever beat the baseline of how long the answer was to our questions actually. What are your experiences?
Actually, I asked the collaborator, the mental disease doctor, whether you can find the patient's disease or not, just by the text or just by the speech. Then they said probably no. So we don't know the baseline actually.
So you actually, again, to respond to both of our questions, you make an important point that what's useful is maybe not the classification, but the features.
Yeah. That's our direction.
We should probably, now that everyone wants to say we have no features in NLP, we should probably talk about this much more, actually.
That's right. But if you want to get some funding, then we have to say it's AI, automatic, with a high accuracy. It's not wrong, right? It's high accuracy.
NLP has been renamed. It's no longer NLP. It's AI for language. That's what it is.
Well, actually, there's another AMED funding project using all of the video of the conversation. And we found that by using video, we can easily find the heavily disease with the 認知症ですね。was dementia people because their face is very difficult. They are quite so we can just find by the faces only. if they are very heavily diseased. So it's for more subtle things, healthy or not so healthy.
I myself have one question about the issue of data opening. Because we know it's very hard to convince some hospital people to make their data get out of their hospitals. For example, in some European countries, there are some projects that work to send the processors into the hospital. And what do you feel about Japanese doctors, hospitals? Do you think that kind of approach would be possible in Japan?
I'm doing this very same approach. So actually, I'm one of the guest staff of the hospital now. Then I'm part of the hospital, so I can touch to the data.
So maybe for you it's fine, but for researchers who are working, so
you need some connection with the hospital. That's a Japanese situation. My other question is, in US, you have the so famous dementia bank. And I wonder how they created such corpus publicly available.
It's so small. It's very, very tiny.
But they agreed, and patients agreed, and the hospital agreed to make the data public. Or US is very good at such publication.
It's also actually difficult to get. So my copy, I had to have my neurologist collaborate with me and ask for it. So he is a specialist in dementia. That's why I have the copy.
So it's not normal.
It's not easy.
If any of your country has some easy situation I want to collaborate with, so let me know.
Longer discussion over beer.
Yeah. And I will join the dinner, so I really want to talk, continue talk in the dinner.
Okay, let's thank to the speaker.
Thank you very much.
And next speaker is Katrina. And the talk is about improving dictionary-based NER using deep learning. Here. Oops.
Kiko is already to JST.
Password.
Really?
Password.
Who knows?
Who knows? So maybe you can use my.
Or we can bring mine.
What is happening? Come on.戻ってこないな。山口さん、あれ使って大丈夫ですか？
いいよ。
なんか戻ってこないな。はい。
I'm sorry for the problem. Oh.
Okay, good. Hi, my name is Katerina. I just started my postdoc a month ago in Lars's lab, and this is the project we are proposing for this hackathon in collaboration with Sampo Puso from Finland. So, in previous years, our lab has developed Tiger, a tagging engine that actually serves as the core of a dictionary-based named entity recognition system. And this system is used to solve a lot of biomedical problems. And actually, in combination with several dictionaries, it can be used to identify specific entities like cellular components, genes, proteins, and all the entities I'm showing here, and then find the relationships between those entities. And afterwards, all these are turned to specific identifiers from databases that are dedicated to them. And they are all available through many resources, like the ones shown in this network. All this data, of course, are available through RESTful APIs, and they all support the Open Annotation JSON-LD standard. The main pro of this system is that it is fast. So it can process actually many PubMed abstracts, thousands of them in a second. So we have one thing, which is the high speed, but what else do we need for a good system? This can be used to do both named entity recognition in massive text corpora, like what I said before, but it's also being used in real-time text mining. So apart from its speed, we need good recall, and in order to get good recall, we need comprehensive dictionaries for each of the entities that we're trying to recognize, but also we need good precision. And how would we get that? For that, we actually need blacklists. But the problem with the blacklists at this time is that they are manually curated. What does this mean? It means that actually we go through the most frequent terms in a corpus, and we identify those that we go through them, and we identify those that shouldn't be there, and they are not actually entities that should be tagged, and we put them in a blacklist. But of course, since this involves manual curation, it can only scale that much. It cannot go very far. So what we're proposing is actually to use deep learning to improve this blacklisting. And what we will do is, what we want to do is to extend the blacklist automatically by actually using the context around the words. So what do we need for that? We need positive and negative training examples. And where do we find those? Our idea for now is to use 3 named entity recognition systems, actually what is used now in String, PubDator, and EVEX. And from the results, we will have tens of millions of text spans on which the systems agree or disagree. So after that, we will, if we have these results, we can create positive and negative examples of context around these entities. But of course, this is our first idea for this project, so if you have any other ideas for how we can create actually the training datasets, which is a very basic part of our work, you're very welcome to communicate those. And after we have this textual context, we will train a state-of-the-art domain-specific deep learning model, and based on recent literature, what we actually plan to use for now is BERT, and specifically BioBERT. So we will have a ranked list of the most problematic names. And what we will do after we get that list back from the model, is to evaluate its quality. After evaluation, we will see if it can be used as is by the nurse system that we have, or if it can guide the manual curation effort. We aim for the first. After we do the evaluation, we hope that the results are very good, and in the future we will be able to incorporate it automatically. But if not, at least it can always help us to guide the manual curation. Then, after we have the new blacklist, we will be able to directly incorporate it into the aforementioned tagger that I said before, and without actually affecting its speed in any way. And since the results and the tagger is available through RESTful APIs, all the results that we will get will be also immediately publicly available. We really hope that this will lead in precision improvement through the improvement of the blacklist, and of course the enhancement of many biomedical dictionaries. Thank you for your attention.
We can take a couple of questions.
So as you've looked at different dictionaries, does the same thing work for all dictionaries, or does it have to be done for everyone?
So, I mean, the first preliminary results that we have, we can see that dictionaries for genes and proteins have more problems than, example, dictionaries for diseases. So, yes, in that case, we will have to look into that more carefully than, for example, diseases which are a little easier to look into. So, yes, we are in the process of finding out what works and what doesn't work, and yes. But there is actually a difference in there.
I myself have one question. So
Yes.
it seems like the assumption is that ensemble system will perform better than those individual systems.
Yeah. Yeah, that the consensus. Yeah, actually.
Do you have any observation that supports that?
Yeah, we actually, again, some preliminary results have showed that, that's where I got the results from the genes, that using each system separately actually performs like much worse than using the consensus. And again, we were trying to see if, for example, for the negative examples, if we have to have all the systems agree on what to tag, like tagging something negative, but for example, a negative entity for a gene can be something not tagged as a gene in general, or something tagged as another entity. Using the same tagging, like all the systems tagging the same thing, works much better. So, and of course the consensus always works way better than the results. But of course we will have to work on it, and so that I can give you more data, exact data about performance.
Of course, the one thing that is important to point out here is the consensus works much better. The consensus works much better in terms of precision. It obviously comes at the massive cost of recall. That's why we don't just want to run the method and use the consensus. The consensus is going to give us a very clean positive set. We're going to have very good precision when all the methods agree that this should be tagged. But of course, the moment one method fails to tag something, the consensus would fail to tag it. So using the consensus would give you terrible. Yes. That's why we don't just go to that.
I have one question. BERT specifically. It works on subwords. How do you plan to? It will just split the word.
In subwords, yes.
Yes. How do you intend to? Because I tried to use BERT previously. In some cases, if you use just the beginning of just the first subword, it might work well for English, but if you use just the first and the last, it's already enough. So how, do you have any idea?
We haven't looked into it yet, but I mean the tokenizer, the word-based tokenizer that BERT uses, actually it was like a problem we were discussing. Will we use that one or not? I mean, I think the pros of using the same tokenizer as BERT are much more than changing a tokenizer, and I think the paper cite BERT, they tried changing the tokenizer and actually they didn't get better results than BioBird. So, but this is something, I mean, I just started, so this is something that we will look into the future, but these are like good thoughts, and these are things that we are looking into and thinking about.
Okay, let's move to the next speaker. Thank you very much. Next speaker is Hijo Nam. She will talk about GNI, Annotated Corpus Annotation Tool.
You connect.
그래.
Hi, I'm Hijo Nam from Ewha Women's University, South Korea, and Professor Park helped me prepare for this hackathon. My proposal is about genomics and informatics corpus annotation tool. Genomics and Informatics Corpus was published in 2018 by Professor Park and others. Before I talk about the corpus, Genomics and Informatics is the official journal of the Korean Genome Organization. It is an open access journal, and all the articles are immediately included in PubMed Central. Recently, it is indexed in Scopus. To collect the base text, we downloaded PDF files of volume 1 to 9 from Genomics and Informatics archives. Then we converted them into plain text files using PDF Miner and OCR tools. We downloaded XML files of volume 10 to 17 straight from PubMed Central. Prototype version of full text corpus of Genomics and Informatics, called GNI Corpus version 1, has been recently archived in GitHub repository. 499 part of speech that are tagged to full text articles are available as a corpus resource under the terms of the Creative Commons Attribution non-commercial license. The annotations are developed automatically. We used NLTK module for general text processing and Ganya tagger for recognizing biological terms. 4 different levels of tags are attached for each word in the sentence: base form, part of speech tag, chunk tag, and name entity tag. The annotation results taken as an example from our dataset. Most RFLP markers were pepper-derived clones, and these markers were evenly distributed all over the genome is as follows. The word RFLP markers is tagged as DNA, and the word pepper-derived clones is tagged as cell line. Because the GNI corpus is automatically annotated, the tagging errors are inevitable. So a semi-automatic annotation tool would conduct name entity tagging on information such as protein names, gene names, and algorithms. In this hackathon, my plan is to design a tool that distinguishes biology term from non-biology term of named entities. The entities will be linked to Wikipedia for evaluation, And this tool would also be designed to be edited manually for precision. It would be an open source project and provide RESTful API for programmable access. JNI corpus and annotation tool will be consistently updated, both in quantity and quality. Now, this is a project I would like to get my own hands on if possible. As an interdisciplinary scientific journal, Genomics and Informatics combines biology, computer science, information engineering, mathematics, medicine, and statistics to analyze and interpret biological data. Thus, the research articles of genomics and informatics may be classified into different groups based on specialty. This page shows K-means clustering with 7 clusters for 245 articles published from 2003 to 2010. Publications in Cluster 1 seems to belong association studies and Cluster 2 to microarray and expression studies. Cluster 3 is related to pathway studies and Cluster 4 to database and computational methods. Cluster 5 seems to be related to studies of protein interaction. Then the keyword for Cluster 6 and 7 are on the screen. We couldn't come up with the right name for these clusters. I would like to find optimal number of clusters and design a module or web service that when a new article comes in as input, it can provide which cluster it belongs by running an embedded algorithm. Thank you.
We can take a couple of questions.
Optimal number of clusters for what task?
Clusters for this journal. K-means cluster.
I never know what would mean an optimal number of clusters. Does it require, does that imply you are looking for some specific kind of information?
These 7 clusters are just example of K-means clustering. So I want to confirm the number of clusters to it, and that means optimal number of clusters.
I don't think any of us know the answer to this question. Does anyone know? Yeah, isn't that task specific?
Data specific. Optimal is like, depends on how many clusters you were able to derive, so it's not going to be an optimal number. They just form naturally, I guess, with data. So
how would I know? How would I know if 7 clusters is better than 3 or better than 14? I don't think we expect you to know the answer. We don't. I don't.
For me, what is missing here is maybe 7 is optimal for watts.
Exactly.
That's missing here. The optimal for watts. What is the goal of the cluster? That's missing here.
That looks great. Why change it?
if my usual method when thinking through these things is simplifying it. So if I were to organize my 4-year-old room, have all the toys, and then say, okay, let's find groups for this toy so I can put them in the bookcase. And I can go crazy with it and say, well, I'll put like the small toys that are pink and red in one, or pink and red in one, pink and white in another one. And so you come up with all these little things that you end up with 1,000 different groups. And of course, the chaos will look the same. It's not gonna look organized, I guess. And so you can do small, medium, and large toys, and now you have 3 bins instead of 20. What's better, I guess, it depends on the application. So if the application is to try to clean up the room the fastest possible, so the 3 bins approach is better in that sense. Now within a single bin, there's gonna be probably small teddy bears together with cars together with Legos. Which, anyways, see what I mean is like, it will depend on the application rather than on a generic approach to it.
By a show of hands, who thinks that's already perfect? I do. What was the category that you didn't know what it was?
I mean, I want to calculate the distance between clusters. From this graph.
What are the clusters on that graph?
The colors.
Okay.
There are 7 colors in
there
this
are
graph.
Yeah.
So
each point is a document?
Each point is a document?
Yes. Each article.
Can you make it big or like us blind people?
Actually, a little comment on this. There are methods. There are methods that try to optimize the number of clusters based on the overlapping of each of documents in different clusters. I don't remember now the name of the method we've used in a recent project. Basically, it will maximize the distribution of papers across clusters, avoiding overlapping as much as possible.
Okay, let's take the speak. Okay, you have a question?
Last question. Looking at your 7 clusters, can we go back to your 7 clusters? It's very naive because I don't have any knowledge on the field on the clustering. But if we, if I'm a biologist, look at your 7 cluster here, there are some words that's for example, cluster number 6, chromosome and region is very general. Human and clone is different. So putting them together leads to maybe something that more general, more confusing. So suggestion is if we start to manually create the clusters with the keywords and try to tell to the system what cluster what document could belong to this cluster. Something that could be doable instead of using the system to detect, because your system can suggest cluster keywords, right?
Can you proceed to check the document?
Not the document, just the cluster, just the list of the cluster, the keywords of the cluster, and just tell if it's correct. For example, for the first one, it's okay, SNP polymorphism association, so it's correct. All these keywords are logically belong together. The cluster number 6, I'm not sure that they all belongs together. There are misunderstanding some words. So we can check the 7 clusters and see some that could be refined, some that okay.
So, to check the documents? Or only the
Or
keywords?
maybe I can check some documents that, but I think it's the cluster.
It's enough to look at the keywords.
Yeah.
I'm our advisor, Professor Han Seok from Ewha Women's University. And actually, we tried a very naive method. We started from cluster number 2 to number 10. And then we measured the cosine distance, and the number cluster 7 was the minimum. That's why we chose it. And the keywords were reasonably well, belonging to that group. For example, cluster 1 was actually SNPs. Cluster 2 was actually microarray expressions. And so if we increase one more cluster, say cluster 8, the distance became larger. So that's why we came up with cluster 7. We didn't use any kind of deep level natural language process. It's just a classic classifications.
Okay, let's thank to the speaker. The last speaker of this session and of this entire symposium is Felipe. Please come front. And he will talk about biomedical machine translation validation and multi-language annotation transfer.
Hello everyone, my name is Felipe. I'm a PhD student at the University of Sheffield, and I'm also affiliated with a university in Brazil where I have a collaboration with Professor Rosanne. And my work is in multilingual bio-NLP, an intersection between linguistics and biomedical field. So recently we have seen so many papers, and especially in conferences like ACL, NACL, talking a lot about making science multilingual and trying to reach other populations. So we can see that at least in 2 papers in 2018 in Nature, they talked about multilingual databases, especially the influence of Chinese articles that people are not looking at the moment, and they are producing a lot, and we have no idea. Maybe we are doing the same thing because we don't speak Chinese, unfortunately. But we can see that technology can play an important role in this case. So this is a study from Aurélie with clinical NLP in languages that are not English. So we can see that French, German, and Chinese are constantly increasing. And this is a search from Zika virus in a Latin American database that includes also Medline. So we can see that most of them are English, but we also have Spanish and Portuguese. And what makes it interesting is that if you look at the Spanish and Portuguese articles, they relate more about the social impact and the regional characteristics than the English ones. For example, the English ones are looking more at cancer applications of the Zika virus. Meanwhile, in Brazil, we are talking about how to prevent the spread and more about epidemiologic analysis. So I don't know why the scholars are like this, but WMT is the main conference for machine translation. So we can see that, for instance, here we can see that the ARC system performs better than the reference in the blind judgment. So we can possibly say that automatic translation is in pair with human translation for this domain. So we may not get completely fluent and perfect translation, but we can get usable translation. And that may be enough for sharing knowledge and making science available for people that cannot speak English, as most of Brazilian doctors, I would say. So, and the other topic is annotation transfer, which is quite recent. So there are two papers, both of them from Spain, where they try to get annotations from English and port them to Spanish or other languages. So most of the studies in the past in Bio NLP were made in English because probably everyone speaks English, but there were data sets available. So if we make data sets available in other languages, they might attract attention of the people. So by applying annotation transfer, we can create data sets in not that costly way of annotating from scratch. So this is an example with European languages. So this is the mantra corpus, which is pretty much the only multi-language corpus. So we can see that that these annotations can be easily derived to the Portuguese or to the French just using word alignments that are like 20 years old, and we can leverage from that. So it works very well for Indo-European languages, but if we look at Asian languages, it might be way more harder. But Chinese is the leading language at the moment, so we need to pay attention on that also. So this I try to do. I'm not sure if this is a good translation. Is it a reasonable translation in Japanese? Is it understandable? Yeah. Are the mappings correct? It's okay? Okay. So, I don't know. So, that's the point. We need to use automatic translation, and if we can, like, crowdsource annotations, get annotations from English, transfer to another language, and people just check, is it okay or not? If it's not, what's the correction that I need to make? Instead of annotating everything from scratch. So, we need to build upon something that already exists. So that's my proposal. So, and this, I have this, does anyone speak Chinese? What is the correct translation for neural cell? But okay. So that's the thing that we need to understand. It doesn't need to be perfect, but it needs to convey the message. So the proposal is to validate if the translation can convey the message, and if there is some incorrect terminology, just correct that terminology and that's it. Not do a fine revision. And then apply the methods that already exist for annotation transfer, and then check if the annotation was correctly transferred. So ideally, a way that I thought about correcting annotations was that if the annotation is incorrectly aligned, just move the annotation inside the text. And if the annotation is missing, we would have like one in English and the other one in the target language. You just drag and drop, and then you just manually transfer the annotation. So the idea is to make things simple. We can use improve on text A and build something upon that. So some of the things may overlap with other participants, so we can maybe talk about how to make things reusable. So thank you for your time, and I'm open to questions.
Hi. Do you know that there is a company that does exactly that? It translates automatically several languages, and then uses the crowd to correct those translations.
Yes, they are Portuguese, but they charge for that.
Yeah, no, they charge, but that's not what I meant.
Yes, yes.
I worked there for a year, so that's why.
Okay, yes, I know that.
They publish a lot too, so there's quite a few papers on these specific subjects. I think will be interesting for you to see.
Other questions? If not, let's thank the speaker and thank you. Thank you for all speakers. I personally enjoyed today's talks a lot. And this is the end of the symposium, and we will join welcome dinner from 6:30, and the venue for the welcome dinner is in the Science Plaza, which is also the Hackathon venue, and some organizers will guide you to the venue. So Yuka, so would you stand up? Yeah, she will guide you to the venue. So the welcome dinner will begin at 6:30. So we have a kind of more than 1 hour. So you can I think it's better to see the venue, and then maybe you can go to the go back hotel, or you can stay in the Hackathon venue to see the where you will be working in following 3 days, and when you will.
Well, we
5:30. 5:30, Yuka will leave for the Hackathon venue. So, thank you for all the participants.